So, good evening and thanks to everyone for joining us today. We welcome you to the webinar today organized by Haryana chapter of ISAR, and the technical partners for this webinar series is Jagsonpal Pharma, makers of Endorec, Divatron and Injection Maintain. So we present to you Endorec micronized Dynogest 2 mg in endometriosis associated pelvic pain during IVF procedures. We present to you Divatron 10 mg micronized tablets of dydrogesterone to improve compliance and enhance outcomes. And we have injection maintain 250 and 500 mg of 17 alpha hydroxyprogesterone caproate to maintain positive pregnancy outcome. So a warm and hearty welcome to all the esteemed faculties and attendees. Please note this webinar is streaming live on Facebook and the link has been shared in the chat box. Now, we invite Dr. Jyoti Malik, Chairperson, Haryana Chapter ISAR and Director Roots IVF at JJ Institute of Medical Services, Bahadurgarh, to kindly initiate the program. Over to you, Manu.
Thank you, Nimisha. Thank you, Jagsonpal. And thank you each one for joining. Thank you, the faculty, the guests, the experts, and the panelists and the attendees for giving us the opportunity to host this program and under the banner of ISAR Haryana with our tagline of Prayas Evam Vistar. So we keep attempting to spread our wings, and this is our Inspire Ignite series 17, where we would be talking on the difficult trio, the RPL, RIF, and the PCOS. So with the blessings of our President National ISAR, Dr. Ameet Patki sir, and the Honorary Secretary, Dr. Asha Baxi ma'am, who are always at the hem of our affairs, who are there always guiding us and giving us guidance about how to go about it. If we have any issues, they are just a phone call away. So many, many thanks to Dr. Amit Patki sir and Dr. Asha Bakshi ma'am for your continuous support and guidance to all of us. So coming on to our first session, it is our first session would be for that I would like to invite our chairpersons. For this, we have our first chairperson, Dr. Nirja Chawla. Thank you so much, Dr. Chawla ma'am, for being here, because I just phoned you up and just a phone call and you said yes to joining. So I'm sure you have with your sort of can I have Dr. Nirja's CV, or we don't have it? So, okay, I have it on my phone here. Dr. Nirja is a gold medalist, has several distinctions, and she's first in the university. She was former consultant at the Department of Obs and Gynaec, Pijmer, Chandigarh. And she has been the vice president of the Foxy North region and founder chairperson of the Indian Menopause Society. She is also ex-president and convener of the Chandigarh Obs Gynaec Society. She has passion for and pioneer for endoscopic surgery in this region. Thank you so much, Dr. Nirja, for joining us. And then the other chairpersons that we have are Dr. Shila Gulia, who is the president of the Bhivani Obs Gynaec Society. I am afraid she was traveling. She may not be able to join. Dr. Surbhi Jain and Dr. Shelza Bansal. So over to the chairpersons to introduce our speaker, Dr. Pratik Tambe. Do we have Dr. Tambe's CV, Nimisha?
Yes, ma'am.
Okay, so can I request Dr. Shelza to do the honor and invite our speaker for today's evening, Dr. Pratik Tambe?
Yeah, good afternoon. Yeah, am I audible?
Yes, Dr. Shelza.
Yeah. So I invite Dr. Pratik Tambe, who is a consultant and gynec endoscopic surgeon at Ashirwad Hospital, IVF, Mumbai. He has an international diploma in advanced laparoscopic surgery from France, and he's trained in ART from Belgium, trained in clinical embryology and ICSI at London and Singapore. He's a member of many council committee members and a council member for ICOG and Indian College of Reproductive Medicine. And he has the honor of receiving too many awards and has contributed to many papers and chapters in various magazines as well. So I invite Dr. Pratik Tambe to start his session on recurrent implantation failure.
And above all, Dr. Pratik Tambe is an amazing orator. And जब हमें मुश्किल टॉपिक मिलता है ना जो हमें लगता है कि समझ में नहीं आ रहा है, so I always feel कि no, let's now call Dr. Pratik and let him explain it to us. So he will be talking today on the genetic causes of recurrent implantation failure. Over to you, Dr. Pratik.
So thank you very much, Dr. Jyoti Malik, Haryana chapter of ISAR, Chairperson Dr. Jyoti Malik, Secretary Dr. Meenu Handa, and the other office bearers.
Both,
Thank you very much.
we'll be talking on both the genetic and immunological, both factors. Yeah, we would be covering up, right?
So
Right.
thank you very much for having me here. It's always wonderful to be with all of you and to contribute to the various different regional chapters of ISAR. I think the last program in May as well, I was here. Thank you very much, Dr. Jyoti, for having me. And I'm going to speak about genetic and immunological factors. I originally gave this presentation at a combined conference of ISAR, IFS, ISHRE, and ASRM, which was held in Jaipur called as Fusion. And I have updated it, of course. It's not a stale old presentation. So let's see these difficult situations, what we can do about them in an evidence-based fashion. There are two things which are infinite, the human stupidity and the universe. And as Albert Einstein said, we are not really sure about the universe, but the extent of human stupidity never ceases to amaze. Let's start by examining whether this subject is actually clinically relevant and whether we have the right tools to tackle RIF in day-to-day practice. There are multiple different publications, especially over the past 5 to 7 years, and I have taken help from all of them. This is a wonderful review paper on the pathophysiology, which was published in Fertile Sterile in 2021. There's also a lovely review paper in RBE, which was published in 2018. And there is a lot of research which is being done on immunomodulation and the immunological factors, much of which, honestly, you and I don't really understand in today's world, but we'll try and simplify it over the next 15 to 20 minutes. This is another paper regarding that. But the elephant in the room is actually this Lugano workshop, which was conducted in Italy. And this is almost 4 years ago in 2022, 3 years ago. And this looks at the various different definitions of RIF, the clinical implications, and what we can actually do about it in day-to-day practice. So this is actually the crux, the substance of the entire presentation that you're about to watch. Recurrent implantation failure, looking at the basics, is actually very rare in clinical practice. If you go by the standard accepted worldwide definition today, and that looks at the number of euploid embryos which have been transferred, not necessarily in one single embryo transfer, but multiple embryo transfers. And if you have 3 euploid blastocysts which are being transferred, not necessarily, as I said, over one transfer, but multiple transfers at different points in time, with a normal endometrium, with a morphologically normal uterus, then the incidence of true recurrent implantation should actually be less than 5%. The problem is that in, for example, clinical practice here in India, we don't do euploid blastocyst transfers for everybody. We rarely do elective single embryo transfers for everybody. And that is what is recommended by most standard accepted guidelines from Western literature. In India, often we do multiple embryo transfers. In a single embryo transfer, we may transfer 2 embryos. We do not necessarily do blastocyst transfer for all our patients. Sometimes we are actually scared that the embryos may not progress to the blastocyst stage in certain patients. And we may actually do a day 2 or a day 3 transfer in those patients. So in that particular clinical scenario, how relevant is this definition? We need to have a slight modification of this definition, and we will come to that in one or two slides. Be that as it may, most of these causes of, in inverted commas, RIF can actually be attributed to embryo issues because you've ruled out the endometrium as a causative factor as per the standard accepted definition. And that is where the genetic factors and the crosstalk between the decidua and the embryo becomes of paramount importance, which is what we'll be discussing soon. If you look at data from multiple centers, and this is from that Lugano workshop, which I was talking about, published 3 years ago, the incidence of true RIF is actually less than 5% after 3 euploid blastocyst transfer. So that should actually be the cutoff. We should, in such patients who are at high risk for RIF, be looking at whether these embryos are aneuploid or euploid. Secondly, we need to rule out uterine causes in all these patients before we attempt an embryo transfer. And that is when we will achieve this equivalence with Western literature. That's something which is utopia. It's never going to happen in clinical practice because there's a lot of jugaad which happens between what is published scientifically and what we actually do in clinical practice here in India. So the practical working definition, at least in the Indian context, would be a failure of implantation when 3 embryos have been transferred in a morphologically normal uterus. Notice that I'm not saying the word euploid here because that makes doing PGTA and embryo biopsy mandatory in all these patients. And we simply don't have those kind of economies because all of our patients pay for the treatment. It's not funded by the government. There's no insurance as yet which funds infertility treatment. So until that happens, that word euploid will have to stay in the background. Coming to the genetic issues, which is a core part of today's talk. Now you'll realize that unfortunately in clinical practice, there are a lot of embryos which we are transferring, which look morphologically absolutely normal. You get grade A, grade B embryos. These are the top class embryos on morphological classification. If you look at the embryos and you have 2 embryologists, one junior, one senior, sometimes you have a visiting embryologist who's coming, and both of them are in concordance. Even then, those morphologically normal embryos may hide some chromosomal issues. And aneuploidies and translocations are the most commonly implicated. If you look at the abortus specimens of women who have had first trimester losses after ART treatment, then a lot of them will have trisomy 16 and 22, or they may have translocations which have resulted in that first trimester loss. Now, these are women who have been confirmed to have a clinical pregnancy. Many of these embryos may implant and they may be lost. You may get a biochemical false positive pregnancy, or you will straight away get a negative pregnancy. Aneuploidy rates, even in blastocysts, can be very high depending on the maternal age or the age of the female partner in ART. It can be as high as 60% in a woman of 40 years and more than 80% if the woman's age is 43 years. And as age advances beyond the age of 37, these blastocysts are going to be overall of poor quality. You will pick that up in your morphological grading, of course. When we look at day 2, day 3 or cleavage stage embryos, which is what many of us still practice in clinical practice, there are a lot of autosomal monosomies, polyploidy and haploidy, which can happen, and therefore these may not actually progress to the blastocyst stage. And that is the one rate limiting factor for most IVF programs or ART labs, so to speak, that we need to have confidence in the laboratory, the culture conditions, and our embryologists to allow these embryos to grow. And out of 4 or 5, even if you get 1 or 2 good quality top class blastocysts, then your incidence of in inverted commas RIF will automatically come down because natural selection will ensure that you are transferring the best embryo in that moment. Also, the endometrium is supposed to be more in sync with a day 5 blastocyst transfer because you're giving 6 days of progesterone before you do your embryo transfer. And sometimes a lot of rejection of the embryo which happens or biochemical pregnancies which happen simply can be ascribed to having shorter duration of progesterone exposure, and the window of implantation, we'll come to that in just 1 or 2 slides, is actually more in sync for a blastocyst transfer. And therefore, we must try as far as possible to do a blastocyst transfer. And the next step, of course, would be to do a elective single embryo transfer. What about mosaic embryos? Sometimes when you do biopsies, you'll find that there are two different cell lines, and these mosaic embryos have decreased implantation rates. This, you don't need me to come and tell you that this has been taught to us since first MBBS, and that has not changed. Science has not changed at all. Biology has not changed much in the past 30 to 40 years. And therefore, if you do a trophectodome biopsy, those embryos which show a high degree of mosaicism, typically the lab as well as your embryologist will tell you that these are not good embryos for transfer, even if they look morphologically normal. The key here is to try and understand that those embryos which have aneuploidies, who have trisomies, who have polyploidies, and those which have mosaicism, morphologically may look very normal to the naked eye, grade A, grade B at most. And you would normally, in the due course of time, 10, 15 years ago, when we didn't have PGT, we used to do an embryo transfer with those embryos as well. This is the main slide for the entire treatment pathway. And I would just draw your attention here to the age group of women who are 38 to 40. And let me be honest and say, by the time most couples come to me for ART, somebody who's senior, who's been in practice for 20 plus 25 years, what will happen is that the routine treatments have already been done. They've already undergone a lot of IUIs, they've undergone maybe a couple of embryo transfers as well. They've exhausted mentally and financially by the time they reach you. And here we have to be able to counsel them and give them a realistic perspective of what is the likely success rate in this particular couple at this point in time. And TGTA works very well in these couples, especially if you cross the watershed age of 37, 38. At the age of 38 to 40, transferring a euploid embryo gives you nearly 59% success compared to less than 35%. And as the age increases, you will see at the age of 43, you'll get nearly 50% success rates compared to almost 15% success. So these are the rough rules of thumb or rough statistics, which I also use in my clinical practice to counsel these patients. And it's important for them to be aware because I don't offer PGT. Okay. So it should not be that tomorrow the patient or the couple comes back and says, Dr. PGT is described on Google as being the best thing since sliced bread. But in my clinical case, you didn't recommend it. Why is that? So at that moment, I can't tell them that I don't offer PGT and therefore I don't entertain that conversation. No, that would be disrespectful. That would not be having a proper informed conversation with the couple to ensure that they have explored all their options. You need to be able to give this information out to the couple and then let them make the informed choice. If they want to go ahead with the PGT cycle, then please go ahead and refer them to an appropriate clinician who will take care of it and do the needful. On the other hand, if they feel that PGT is expensive, it's not something which they can entertain at this point in time because they're already financially exhausted, then you are well within your rights to go ahead and do the best that you can under the circumstances. The genetic tests which are recommended by evidence are mainly those which are related to thrombophilias, that's the factor V laden mutation, antithrombin 3 protein CNS. And usually, if you don't do it, somebody else has already done the entire APLA panel by the time the patient comes to you, not once, but multiple times. And often they'll be from different labs, there'll be different reports, and they will confuse you and obfuscate you. That is where your experience and expertise as a clinician comes in. DNA fragmentation has been pointed out increasingly as the paternal cause for first trimester losses, recurrent pregnancy losses, especially which do not progress beyond 6 to 7 weeks, and a lot of biochemical pregnancies as well as recurrent implantation failure. Unfortunately, while it's very easy to say that anybody who has a DFI of more than 30% is more likely to be prone for an RIF, there aren't enough large population studies to show that improvement in DFI equates to a much better live birth rate. That sort of evidence is going to take time to generate, I expect. And over the next 4 to 5 years, we may get more of those studies. But as of now, prescribing antioxidant therapy, demonstrating that the DAPI has come down, using a shorter abstinence period before the sample is ejaculated on the day of the oocyte retrieval. All of these are very good practical solutions that we can offer couples, and most of the time they are not very expensive at all. Now, the elephant in the room needs to be addressed, and that's ERA testing. Now, ERA testing is endometrial receptivity array, and as we said, even in a morphologically normal uterus, a lot of endometrial receptivity issues may be there, which are there beneath the surface. The endometrium will be very nice trilaminar or pentalaminar on the day when you're going to start progesterone. It will be 8-9 millimeters in thickness, very good subendometrial blood flow, satisfies all the criteria for starting your progesterone to do your embryo transfer. But unfortunately, what we don't understand is that the window of implantation and the morphological appearance on a transvaginal scan, these are two totally completely different things. The window of implantation varies from patient to patient. It also varies in the same patient from cycle to cycle. And transferring a good euploid embryo, ideally a blastocyst, a single blastocyst, at the perfect time in that window of implantation, that is the theory, will give you maximal clinical pregnancy rates. Unfortunately, what has happened is that there are a lot of studies both for as well as against ERA testing. And the most recent human reproduction systematic review and meta-analysis says, and that's the last line there, like most Cochrane meta-analysis, is that data is insufficient. We need more data. We need better randomized controlled trials. We need better conducted trials. So these are 2 or 3 tests which you will hear mentioned quite frequently. That's the EMMA, ALICE, and the DICE. And they require an endometrial biopsy to be done typically around day 20, day 21 of the cycle, because that is supposed to be the most fertile period as far as the implantation window is concerned. And this is processed by next generation sequencing, and you will get the report after about 2 to 3 weeks. So you must counsel the couple that after the biopsy, you're not going to be able to do the embryo transfer immediately. Transfer ideally is going to happen in the next cycle. And if you combine your ERA with the other tests, that's EMMA and ALICE, EMMA looks at the endometrial milieu and ALICE looks at chronic endometritis. These are supposed to take care of a lot of the, how can I put it, endometrial factors as far as your implantation is concerned. Now, we began by defining RIF as something which happens in the presence of a normal endometrium, a morphologically normal uterus. Many of our patients have not had a hysteroscopy before the embryo transfer is done. I still see even today 2 or 3 embryo transfers being done when the couple has never been offered a hysteroscopy. So especially in Indian patients, do offer a hysteroscopy if there has been 1 or more failed embryo transfers. If you can try and combine it with an ERA in that same cycle, that would be ideal. ERA classifies your endometrial staging into 7 different possible phases. But unfortunately, as I said, there is data both for as well as against it. Those who do it swear by it, and those who are opposed to it are very violently opposed. So you have to personalize, you have to take whatever best you can. It's an expensive test. And one of the fallacies of the test, one of the most, how can I put it, vocal criticisms of the test is that it biopsies the endometrium in one cycle and the transfer takes place in the next cycle. And therefore, as we said just a couple of minutes back, in the same patient, from one cycle to another, the window of implantation may change. So that correlation may not be exact. And that is one of the big stumbling blocks or hurdles, criticisms, which simply doesn't go away. The second part of my talk is to talk about immunomodulation and immune regulation. Now, this is a very boring part of the talk. It's extremely theoretical, and I will forgive you if you go to sleep for the next 10 minutes. But bear with me because this has very important implications for the therapies that we offer our patients when we are dealing with RIF. So, at the very basic level, we know that all zygotes or embryos are half self and half non-self. The half self comes from the maternal antigens, whereas the half non-self comes from the paternal antigens. And this trophoblast apposition, adherence, invasion, implantation, call it what you will, is a very complex interaction which honestly we still haven't completely understood. There are a lot of factors at play. There are a lot of complex interactions which are taking place underneath the surface. But what is known is that the fetal antigens, especially those which come from the paternal side, could trigger an immune response and cause what we call blastocyst rejection or lack of trophoblast invasion. Is it possible to identify the agents which cause this unfavorable maternal immune response? There are multiple endometrial markers specifically which have been studied, which immunohistochemistry and advanced testing in immunology labs, which are associated with this immune dysregulation. And as you will be aware, for many couples who have recurrent implantation failure, as well as recurrent pregnancy losses, those who have 4, 5, 6 losses, immunotherapy is one of the prime ways in which we can try and treat these patients. Whether it's solid, whether it's evidence-based, whether it works consistently in patient after patient, that is something which is very difficult to speak because you can't have cases on one hand and controls on another and do a randomized control trial. Each patient is unique. Each patient has their own issues, and you need to individualize the treatment on a case-to-case basis. So at the very basic level, we know that the uterine natural killer cells are responsible for regulating the trophoblast invasion, and there are interactions between KIR and HLA-C molecules, which are at the basic concept of immune dysregulation. So this KIR comes from the mother, which is part of the natural killer cells in the decidue, okay? And the HLA-C comes from the paternal aspect of the blastocyst. And these interactions, it has been proven, are actually regulated by these KIRs. And KIRs are of two types, A and B. A are inhibitory, B are activatory. And specifically in Caucasians, the KIR-B is endometrial protective, embryo protective. So if you have a preponderance of KIR-B on histochemistry, we know that there are not too many issues, and this particular case of RIF will not require a lot of, how can I put it, immunotherapy to achieve implantation and continuation of pregnancy. Whereas KIR-AA are at greater risk of embryo rejection. And again, HLA-C is something which is still an unknown entity. So these aberrant immune responses are not only seen in recurrent implantation failure, they're also seen in adenomyosis, PCOS, endometritis, endometriosis, obesity, PCOS, and so on and so forth. I will quickly examine those over the next 2 or 3 minutes because I've already spoken for 20 minutes and I want to finish in 30. So the mechanism of RIF in these specific conditions, in adenomyosis, you're going to have a lot of chronic inflammation, which is well known, and a lot of cytokines, prostaglandins, interleukins, TNF alpha, transforming growth factor beta. All of these molecules are going to be raised and they're going to be chronically raised, because of which your oocyte quality is going to be good. There is a greater danger of phagocytosis of the embryo, and obviously implantation is not going to be taking place. There are actually 25 different proteins which have been identified to be changed. The levels are changed in patients with adenomyosis, and therefore women with adenomyosis, especially those who have a lot of changes at the local level, excess of estrogen, lower levels of progesterone, along with the immunomodulatory changes which we just described, all of these will lead to lesser chances of implantation and greater chances of miscarriage in women with adenomyosis. In endometriosis, it's very similar to adenomyosis. You'll see a lot of macrophages, immature dendritic cells, and Treg cells. And this pro-inflammatory state is mainly the pathogenetic mechanism which is associated with implantation failure. We always feel that doing an IVF cycle in an endometriosis patient is quite difficult. One, they behave like poor responders. The oocytes that you get are typically of poor quality, lesser chances of the patient progressing to blastocyst formation. And once all of that has been crossed, then you will find that unfortunately the endometrial receptivity is poor in these patients. And that is actually owing to a lower frequency of KIR3 and frequency of inhibitory class 1 patterns. As far as chronic endometritis is concerned, endometritis is rampant in a country like India. Often it is unrecognized, it's simmering beneath the surface. A lot of patients who have RIF, what we define as RIF in our country, is actually chronic endometritis in disguise. And if you do a biopsy, you'll find that there's a lot of local macrophages, phagocytosis, and a greater percentage of CD68 plus, which is seen in these women. In PCOS, there are again changes with the CD68 plus and a lot of natural killer cells. And these actually are responsible for the chronic local inflammation, which is seen in women. Even if you control their obesity, you lower their BMI, this low-grade inflammation is always simmering beneath the surface, and it is directly proportional to the incidence of reproductive failure. There have been studies which look at transcriptome, and they found that there are multiple changes in the endometrium profile beyond the scope of today's discussion to talk about it, and I would not be the right person to talk about it. They've sampled over 60,000 endometrial cells and arrived at a signature, just like you have a particular signature which is there in ERA testing, which tells you whether the endometrium is favorable or not. Similarly, they've done these transcriptome studies and they found that there's a particular signature in that endometrium which tells you whether it's favorable. The last part of the talk is very practical, and this applies all the knowledge that we have gained so far. And we need to know what options we can offer these couples to ensure that there is going to be good results as far as treatment is concerned. LMWH has been around since donkey's ages. In fact, 15 years ago, I was a very vocal proponent of LMWH. But with the benefit of hindsight and a lot of meta-analyses which have been published, it's been found that specifically in patients with RIF, there may not be significant improvement. There are identical implantation rates, clinical pregnancy rates, and live birth rates when women have been administered LMWH. The more promising agent is tacrolimus, and some of you may have heard this. This is very widely used in immunotherapy patients, especially those who have recurrent pregnancy losses. And this is an immunosuppressant. It is, you're on very solid scientific ground if you can demonstrate an altered Th1 Th2 ratio. Remember, Th1 are the bad guys, Th2 are the good guys. Having more Th2 means continuation of pregnancy. Having more Th1 means the embryo is likely to get rejected, or you can have a post-trimester loss. The reason why people are very fond of tacrolimus, especially in the immunotherapy domain, is because look at these figures, 45% implantation versus 0%, 60% live birth rate versus 0%. And these are not my figures, these are from Japan. So I'm pretty sure that whatever figures these people are quoting are very rock solid evidence-based study. We don't have similar figures from India, unfortunately. When you use it in your clinical practice, you will actually be able to identify whether this works in your population. IVIG was something which was very much in fashion a decade or two ago. Again, in women who have Th1, Th2, which is altered, elevated natural killer cells on immunohistochemistry, it's been found that the results are 34% versus 13%, clinical pregnancy rates of 60% versus 40%, and live birth rates. Look at this. 50% versus 30%. In clinical practice, if anybody gave me something which I could use in my patients, which made even 1% or 2% difference in my results, especially in this difficult to treat group of patients, I would be very happy. You have an agent which is giving you 50% live birth versus 30% live birth. So this is something which really needs to be tried in this particular group of patients. Again, we may not be the people who have a lot of experience with it, so we need to have a multidisciplinary team approach. PRP and PBMCs are well known. This is the first port of call for most patients who have thin endometrium. And very strictly speaking, patients with thin endometrium don't fall into the RIF category because there the uterus is not morphologically normal. But in India, we have a tendency to club thin endometrium along with RIF for reasons unknown to me. So I'm just quickly going to go over this in a couple of slides. Clinical pregnancy rates of 40% versus 14%, live birth rates of 33% versus around 10%. So this is something which is very promising. It's easy to do even at a small standalone daycare IVF center. You don't need to have a big posh tertiary care institution where you're going to use it. GCSF again is one of the agents which we use widely in patients with thin endometrium. Again, thin endometrium, very strictly speaking, is not RIF. because RIF requires a morphologically normal uterus. But having said that, look at the clinical pregnancy rates, 48% versus 25%, nearly a doubling of the clinical pregnancy rate. And it's not expensive at all, can be easily administered. And many patients, especially in my clinical practice, have benefited a lot with just these two therapies, GCSF and PRP. I'm not going to talk about stem cells today, but I will give you one good slide, which is a summary of all the therapeutic interventions that we've discussed so far. Tacrolimus, IVIG, PRP, and GCSF. All of these are good evidence-based options that we can offer our patients today. As far as LMWH is concerned, we usually add it to the entire mix or the masala that I like to call for these patients, but it's not something which is very strongly evidence-based. Last two slides about the uterine microbiome. We know that the cervical and uterine microbiome makes a big difference as far as implantation is concerned, and the presence of non-lactose dominant microbiota are strongly associated with implantation failure and first trimester losses. There are multiple pathogenetic mechanisms behind it. Simple treatment with doxy and flagell gives you 88% cure rates in the infertile population. And you don't need me to tell you that tuberculosis is rampant in Indian women, especially in that population which presents to you with RIF. When these women are treated with simple antibiotic therapy, the improvements in live birth rate are startling, 60% versus 13%, and natural conception can be 66% versus 6%. All of us know from anecdotal experience that a woman who is put on AKT for genital COX sometimes spontaneously conceives on her own while she has had multiple failed treatments previously. And that, of course, you can see here after 6 months of AKT, clinical pregnancy rates can be as high as 90%. Excellent forest plots, improvement in clinical pregnancy rate and live birth rate. This is my last slide. Just like you have fecal transplants, which are advocated for people who have Crohn's disease and ulcerative colitis to restore the microbiome, the gut microbiome back to normal. There is a theory that vaginal microbiota transplants can also be tried in women who have refractory, non-responsive chronic endometritis, and this could be something which can be used in future. So to conclude, ladies and gentlemen, as I said, you need to have at least 3 euploid blastocyst transfers in a morphologically normal uterus to define RIF. Unfortunately, most of us don't do PGT. Many of us don't do ERA. Quite a few of us, unfortunately, still don't do hysteroscopy, even though it's widely available. It's cheap and it doesn't cost a lot of money, and you can pick up a lot of uterine pathologies with a simple 3D ultrasound and a hysteroscopy. We know that genetic issues are quite common. Immune tolerance, unfortunately, is not very widely understood. It requires a lot of expensive tests. The treatment sometimes is cheaper than actually doing all those expensive immunohistochemistry tests. But having said that, KIR and HLA-C interactions are of key importance. All immunotherapy that we offer our patients actually works at this KIR and HLA-C interaction, which allows for blastocyst implantation. Targeted therapy is backed by robust evidence. There are a few which we've listed a couple of minutes back. But finally, you have to individualize your treatment based on your patient at particular what point she is in a reproductive pathway, and try again until we succeed. Thank you for a patient hearing. Thank you, Haryana Chapter of ISAR, Dr. Jyoti Malik, for having me.
Wonderful. That was great, Dr. Pratik, and absolutely, I mean, very clear, very crystal clear. You've made what is the etiology, how to define RIF first of all, and what is the treatment actually. So over to Dr. Nirja for your comments, and then maybe we can take questions as well, 1 or 2 questions if need be.
I think, Dr. Pratik, your presentation was excellent. I was checking out the comments. They're all saying hello to you, but they have not dared to ask you any question. But if there's anybody who wants to ask live or just now, they are most welcome, as long as he's here with us.
Practically speaking, what is your cocktail that you use for RIF? I mean, tests and
Well,
everything you said are very, very, very costly. They may not be, everybody may not be, I mean, they may not be accessible to some of us. And also the results may not be, if we get everything fine, what all we should be trying in these cases of RIF? What is your take, mantra, guru dose, guru cocktail and masala?
So PRP, GCSF, PRP if there is thin endometrium, GCSF whether or not there is thin endometrium. LMWH we use for almost everybody, though the evidence says it doesn't work, very honestly. Practically we do use it, in especially in those patients who can't afford anything. Tacrolimus I have tried only in a couple of patients, very honestly. I don't have very good experience with it. But IVIG is strongly recommended by a lot of people who practice immunotherapy in association with tacrolimus. And they've got good results, they've got consistent results, especially in patients who have had 4-5 miscarriages in the past. Not necessarily RIF, but in RPL. So a lot of this evidence is conflicting. A lot of it has, how can I put it, overlap with patients who have recurrent pregnancy losses as well. And obviously in patients who have recurrent pregnancy losses, you first need to rule out genetic causes. And after the genetic causes are ruled out, then you go on into your different immunotherapy experimentations. The first and most important always is to rule out a transmitted pathology like a translocation or a trisomy. That would be the first protocol.
At what point in your investigation of the RIF couple do you actually advise a hysteroscopy?
So anybody, let me put it this way. Western literature says that you offer a hysteroscopy only if somebody has previously had a failed embryo transfer. I am primarily an endoscopic surgeon, so I always offer a hysteroscopy at the very least or a hysterolaparoscopy at some point during the treatment pathway before the patient is put up for any RTSR.
Yeah.
So you suggest hysteroscopy for all before even the first IVF?
In Indian population, yes.
Right.
Before the first IVF doesn't have much literature
True.
to support.
That is what the Western literature says, that only if you have a previous failed implantation, you have a failed IVF cycle, then you offer your hysteroscopy. But
Yes.
often it happens, and this is practical experience, even patients who are from very good class of society, very good, well-educated patients, will turn out to have some or other pathology which is there in the uterus, which you can correct before you put her up for ART cycle. There are patients who, when you offer them hysteroscopy after a failed ART cycle and you identify some pathology, then they turn around and say, why didn't you ask for a hysteroscopy first? Why did you make me spend 1.5 to 2 lakhs and waste my money? Now you do a free cycle for me. It's all your fault.
Yeah, actually, it depends upon how you counsel. And there
Exactly.
are many people, many of us who would not do a hysteroscopy routinely before the first IVF and probably only do it after the failure.
Correct.
Because
That is the evidence-based answer.
yeah, because we do have very good sonologists who can actually see some
Correct.
pathology. And if there's any pathology which is, say, just around 1 centimeter, removing it may not add to any benefit. So it's better to give her a trial. And if it doesn't work, because many people will succeed with just what you have before doing an hysteroscopy.
Yes, especially if you have multiple failures, you have recurrent implantation failures, then hysteroscopy, PD ultrasound, subendometrial blood flow, all of those tests which are recommended in the research papers, they would be your first protocol.
So
Right. Thank you so. Thank you. Thank you. I don't think our rest of the chairpersons I can see. So we move on to our second session. And for that, I invite the next set of chairpersons, Dr. Sarita Kalra. Actually, the names are not written there, so I'm not able to find out who is there. On every this thing, there is written only doctor. So it is a little confusing. Maybe that is why it is difficult to find out who's joined and who's not. If you can please, on the right hand of your screen, you have a blue sort of a box with 3 dots. If you can rename yourself, it would be easier, because in the panel again we would be a little lost if we don't see the name and all. So if you can please do that, thank you. And for the next talk, we have chairpersons, Dr. Sarita Kalra, Dr. Rakhi Malhotra. Dr. Sarita is from Hisar, and Dr. Rakhi Malhotra is our senior vice chairperson, Haryana ISAR. Then we have another Dr. Kalyani from Bhiwani and Dr. Meenakshi Mehta again from Hisar. So I would like anybody, any chairperson, I am not able
Yes,
to.
yes. Hello, Dr. Jyoti.
Okay, Dr. Rakhi is there, right? Dr. Rakhi, can you? Okay, it would be an honor to invite Dr. Rakhi by Dr. Rakhi. So please do the honors, so we can have our another very
So,
important, very dear friend, and a very a good orator and a person who has done so much work under this in her tenure as the chairperson of this endocrinology committee. So hats off to Dr. Rakhi for doing
yes.
such a great job. And now I request Dr. Rakhi Malhotra to invite Dr. Rakhi Singh.
Wow. It's a thank you, Dr. Jyoti, for giving me this honor. And it's first of all, I really compliment Dr. Jyoti and feel proud to work under such a dynamic chairperson of a Haryana chapter of ISAR. Now I welcome Dr. Rakhi Singh, who is the President of Noida Society and Governing Council member of ICOG 2024 to 2025 and Vice Chairperson of UP Chapter ISAR. She is our candidate for Foxy Vice President North 2025. And best wishes to Dr. Rakhi. And we welcome you for this talk. And she has been given so many awards. So many achievements and publications are attributed to her. And we feel proud of you, Dr. Rakhi Singh, for such a fantastic achievements. Welcome, Dr. Rakhi.
Thank you, Dr. Rakhi, for it's my soul sister who's invited me over here, and I'm happy for that. And thank you, Jyoti and Meenu Handa, the office bearers and the close friends of mine, whom I have been admiring and walking through a long way. And for today, I have been ordered and given the task of talking on origin of PCOS. And let's see and understand what the origin of PCOS means and what is its disease burden, from where we are starting and where we are heading to. As we all know, 65% of the women in India are unaware mostly of the PCOS symptoms, except for the metro cities where they are quite aware and over aware of the symptoms. And we all know it affects around 4 to 20% of the female of the reproductive age group worldwide, and most commonly cause infertility in the woman. Primarily, it is characterized by ovulatory dysfunction, hyperandrogenism, and it encompasses a spectrum of clinical features. Let it be hyperandrogenism, the menstrual irregularities, PCOM on ovary, or the obesity and insulin resistance, which could be seen. And there are various causes for the PCOD. If it to be diagnosed, it could be either the insulin production, which could be excess, the excess androgen production. Low-grade inflammation is the thing which leads to all of them, and there could be a hereditary factor involved also. And hyperandrogenism, or the ovarian dysfunction, aberrates the gonadotropin releasing hormone pulsations and results in abnormal gonadotropin secretions, which would lead to insulin resistance and the ovarian dysfunction, which we all know, which we've been understanding and learning over the ages, and which would ultimately lead to PCOS, which is a far more common thing, is hyperandrogenism, which occurs in PCOS, and the causes would be disruption of the normal ovarian or the adrenal function, resulting in the production of excess androgens. There is dysregulation in the neuroendocrine system, leading to imbalance in the hypothalamo-pituitary ovarian axis, leading to overproduction of the gonadotrophins, what we see, and a disharmony present in these gonadotrophin hormones, the LH and the FSH. And this hyperandrogenism is caused by the intrinsic dysfunction of the theca cells and or the hypothalamo-pituitary ovarian axis, and it is exacerbated by the high amount of AMH concentration, what we see. And this excess of androgens secretion induces visceral adiposity and adipocytes in dysfunction. The hyperinsulinemia that develops secondary to the insulin resistance stimulates the androgen secretion by the theca cell and modulates the effect of gonadotrophin on the theca cells. And as it is, we all know that environmental factors also do play a role, and these impact such as nutrition, the pollution, and the mediating genetic and the epigenetic pathways which are seen, so that the PCOS is getting in the formation. The environmental insults adversely affecting the exposed person, but it not only affects that single person, it affects for the generations and the lives to come. And when we talk about the development origin, during the adult health care can be influenced by exposure during the adult life, during the infancy or very early childhood. Anyway, any age, it can be starting of it. And whenever the mother is pregnant, it is not only she is pregnant with her very own child, she is also pregnant with her great grandchildren also. So whatever she is eating, whatever she is going through in that duration of time, it affects the genomic sequences also, and the formation of PCOS starts then. So any PCO patient, what we are seeing today, could be the genetic variation of the changes which have happened when she was as a fetus itself. And preconceptional care is important for these patients, and it improves the health status and reducing behavior and individual and environmental factors that could contribute to the poor maternal and the healthcare outcomes. Its ultimate aim is to improve the maternal and the child health outcomes in both the short and the long-term gains what these patients have. And preconception care is the provision of the biomedical behavior and the social health interventions to women and the couples before the conception occurs. So we need to counsel our patients that she need to decrease, shell out the excess amount of weight if the BMI is more than 23. And if there is insulin resistance, that has to be corrected. And any other hyperandrogenism factors, that has to be corrected to a certain extent, and then going for the pregnancy. That would help the genomic sequences not being transmitted to the fetus itself. And a word about the fetal origin of adult diseases. We know by now that it is there, and it is now widely accepted that the risk of number of chronic diseases in adulthood, such as diabetes, hypertension, coronary heart disease, may have their origin before the birth of the child only. So preconceptional counseling is very important, and to make the patients understand. It is known by the Baker's hypothesis, which was revealed in 1980, and there is a high correlation between the infant and the adult mortality. Association between the low birth weight and the adult ischemic heart diseases is very well known, and there is a lead to this fetal origin of adult diseases and the early programming hypothesis in PCOS also. The intrauterine environment is contributory to the future development of PCOS, and intrauterine nutritional restrictions result in the changes to the insulin level and this insulin resistance within the fetus, and addition to the possible epigenetic changes which are there. Exposure of the fetus to excess androgens resulting in the programming and changing to the differentiation of developing tissues, which is seen. And what happens with this programming? It involves the structural changes in important organs and alters the cell number, imbalance in the distribution of different cells type within the organs, and altered blood supply or the receptor number is seen. There is proposed natural history of PCOS that we very well know. That even at the fetal age, fetal life, the mother is, if having hyperandrogenism, the fetal also will have other symptoms like during pregnancy, the fetus will show low birth weight or the rapid gain in the weight would be there during the childbirth, after the childbirth, during the toddler's age, and premature adrenarche or the pubarche is seen. And during the adolescence, the child would definitely show up all the symptoms of hyperandrogenism and insulin resistance at puberty. And this child ultimately will have subfertility and infertility and a full-blown PCOS later on. And the abnormal form of insulin secretion or the action would lead to type 2 diabetes, reduced vascularity in the ovary and the other parts of the body, could lead to hypertension or the cardiovascular diseases later on in life. The maternal environment and the paternal and the placental physiology definitely plays a role for the fetal environment and intrauterine environment for the placental unity. Thus, having a genomic sequence change, alteration is seen in the fetal growth, interactions with the pre and the post natal environment which is seen. There are various environmental factors which are linked with PCOS, the EDCs, which could be the dietary related weight gain, the gut microbiota, lack of exercise, the physical activity, socio-economic status, advanced glycination products, which are taken during the diet, also plays a major role. Let it be the frozen fast foods what the patient eats, or the uncooked, the animal derived, or the frozen foods, or the junk food what the patient is having. Even in the thermally processed foods, they play a major role in the formation of PCOS. And these EDCs pose the greatest risk during the prenatal development by causing irreversible changes to differentiating tissues. And there is definitely a EDC crosstalk between the placental barrier, and this is hypothesized that the prenatal exposure to the endocrine disrupting chemicals may contribute to the PCOS development, what we all know. And post-delivery, these children have either obesity or the changes in the metabolism, the thyroid dysfunction, or pubertal variations which are seen. So we come to know that this child may be having PCOS in future, or they may be at risk for PCOS. A word about the LH hormone. There is a dysregulation which is seen because of the abnormal secretion of the ovarian and the androstenedione, and an intrinsic property of PCOS through the theca cells. And this would lead to increase in the LH secretion. Thus, we know why the obesity is there, and decreased AST synthesis and the development of insulin resistance is a result of which, both of which decrease LH secretion and independently of each another what is seen. And when we talk about hyperandrogenism, let it be the obese patient or non-obese patient, we know that there is increase in LH secretion. The IGF factor affects the theca cells, and thus the increase in the P450C alpha activity, which is seen, thus leading to increased androgen secretions and decrease in the sex hormone binding globulin, which is there. And when we talk about the follicle development, the elevated androgens are impairing the contribution to the abnormal gonadotrophin and the gonadotrophin hormone secretions, which would impair follicular development and increases the ovarian androgen production, which would ultimately lead to neuroendocrine abnormalities and hyperandrogenemia, which is seen. And when we talk about the folliculogenesis and the follicular defect, how the follicle grows, there is an accelerated early follicular growth in the very early stages from the primordial follicle or the primary follicle stage. And when the follicle reaches the secondary preantral follicle stage, there is a reduction in the FSH response if premature luteinization is seen during that stage. So that is why the number of multiple small follicles are seen at the periphery of the ovary and follicular arrest, which is the reason for it. And there is a disordered folliculogenesis because of the excess androgens and reduction in the level of oocyte secretory growth factors, mainly GDF9 and BMP15. And there is thus leading to arrested follicles, which are hyper-responsive to the gonadotrophins and prematurely reach a level of maturity where there is a production of high level of circulating E2 and suppresses FSH, which prevents further the development of healthy follicles in the cohort. And there is a deficiency of FSH, which impairs the aromatization of the androgens to estrogen and impairs the follicular development and maturation. And the luteal progesterone, which releases hyperandrogenism, and the ovulatory dysfunction happens ultimately. When we talk about the genetics, although the genetic factors are known to be involved in the pathogenesis of PCOS, the environmental factors involved in the pathophysiology of PCOS may include prenatal exposure to the intrauterine environment of the mother and the fetus, the follicular microenvironment, and the lifestyle following the birth of the intrauterine environment of the mother with the PCOS, and the follicular microenvironment changes over here. There are various gene mutation changes which are occurring at the various levels. Let it be the ovarian androgen steroidogenesis, insulin secretion action, or the effect of steroidal hormones, the gonadotrophin actions, and regulation and the other genes which are seen, and these mutation expressions are seen in this PCO patient. A word about the endoplasmic reticulum stress factors. ERS develops in the follicles and forms a key component of the pathophysiology of PCOS. The local hyperandrogenism in the follicular microenvironment activates the ER stress in PCOS. This ER stress contributes to the pathophysiology of PCOS by affecting the function of the granulosa cells, and this ER stress induces the expression of multiple genes that are associated with cumulus oocyte complex and expansion of the GC via the notching and the signaling, which is known. There is definitely a perinatal exposure to the excess of androgens and the daughters of the woman with PCOS. And these daughters with PCOS women who are mothers, who are perinatally exposed to high concentration of androgens, have a larger anogenital distances. There itself, we know this child is at risk for PCOS in the later life, and which would serve as a biomarker of intrauterine exposure to excess androgens during the fetal and the neonatal period, as well as in the adulthood. So, excuse me, the serum androgen concentrations are higher in women with PCOS than in those without it during pregnancy. So that is the reason why androgen excess has to be corrected during the perinatal period itself, preconceptionally, and then the pregnancy has to be planned. The the placental tissue from the woman with PCOS is characterized by high activity of 3-beta hydrosteroids and dihydrogenase, and a lower activity of P450 aromatase that can from the woman without PCOS, which could also explain the hyperandrogenic intrauterine environment of the pregnant woman with PCOS. There is a link between the gut microbiota and the various physiological pathological conditions, as there is dysbiosis on the gut microbiota has to be corrected so that future PCOS is not there. And there is a big role, and there is an inflammation which is part of it, which has to be corrected. There is seen a decline in the microbial diversity, which was characterized by decreased beneficial bacteria and increased pathogenic bacteria in the gut. And this gut microbiota metabolizes the substrate, entering the gut via the diet and produces the metabolites that may act directly on the intestine or enters the systemic circulation and influences various host tissues such as the ovary, liver, skeletal muscle, the adipose tissue, and alters these in these PCO patients. And secondary bile acids, short chain fatty acids are a few gut bacterial metabolites which are altered in these PCO patients. So interventions and the probiotics we know is very important to restore gut microbiota, and ultimately if the gut dysbiosis is corrected, so it does not leads to PCOS, and it would correct ultimately insulin resistance, hyperinsulinemia, and hyperandrogenism. To conclude, it's all a complex physiology which has to be corrected, because these epigenetic changes are induced because of the environmental toxins, the diet what we eat, which would, if it is not correctly taken up, then the patient would have high androgens, insulin resistance, hyperinsulinemia, adipose tissue problems, and there's a vicious circle which would start upon and ultimately affect the pituitary and the hypothalamo-ovarian axis and lead to increased androgens and the other problems. And we propose the pathophysiology of PCOS. We know very well that the insulin resistance, hyperinsulinemia, LH and FSH dominance is there. And there would be definitely ultimately leading to follicular arrest, anovulation and amenorrhea, and irregularity in the cycles. And that is what we know. And it has to be tackled. It's a vicious cycle. It has to be tackled. The mother who is planning to be pregnant of a PCOS character, the obesity has to be corrected, and further upon, it has to be checked and taken. A mother is a family, the richest possession of being priceless worth is there. At the outset, I would like to tell all of you, I'm standing for Vice Presidency of North Zone. Please do consider me for the elections which are there from 1st to 10th of August, and do vote for me. Thank you. And thanks to Jyoti, Dr. Meenu, and the whole Haryana ISAR team for giving this opportunity.
Well, Dr. Rakhi, it was a wonderful eye opener, and I must say that I am also worried for my future generation now. I mean, it's high time that we need to educate our young girls who are the future mothers, so that this PCOS can be checked in, because lot of patients are coming out the PCOD patients we see in a routine OPD, and it was a wonderfully insight you have put in, and congratulations for such a wonderful presentation, and best wishes for your candidate. Thank you, Dr. Rakhi.
Thank you, Rakhi.
Thank you so much. Thank you, Dr. Rakhi Singh and Dr. Rakhi Malhotra, for your comments and for chairing. And definitely not only the genetic part, but epigenetic, environment, diet, gut, everything we have to take care of. And the in depth, the etiology and etiopathogenesis that you've explained really makes us understand the whole process, why it is so difficult and why we are not able to control, and why it is increasing actually day by day.
Basically, the lifestyle modification which has to be done, the BMI has to be corrected. It has to be less than 23 for the Indian population. And once it is corrected, then only she should plan up for the pregnancy, so that the insulin level is corrected, the hyperandrogenism is corrected to a certain extent, and the obesity is corrected. That's how she's not going to transmit the disease to a greater extent to the offsprings and the great grandchildren of us, and the genetic mutation is avoided.
Right.
Very good lecture, Dr. Rakhi Singh. Let me ask you, don't you think that it is so difficult to manage the lean PCOS patients than the obese one?
Ma'am, it is not that very difficult, because it is a myth that the lean PCO patient doesn't require to do exercise, doesn't require to do all that. But believe me, you that all the lean PCO patients also require all the more same amount of it, because there is an insulin resistance which is there, the hyperandrogenism which is there, and they require little edge above the attention which has to be given for them, and the equal amount of exercise has to be done for them also.
So, but the thing is, like when these lean PCOS patients, they are coming to us, and the moment we say to them about the exercise, about the diet, they are not able to understand. They say already we are so thin, and
So you
still we
have
are
to
not.
counsel them
That
the
they are
other
doing
way around.
exercise, they are not eating the outside food, but still. So what I want to say is that it is something else is there in the environmental factors are there in our diet. All these in the diet, the pesticides, I think these are the another things, environmental factors, they are playing a lot
Major
of role in this.
EDCs are there, endocrine disrupting
Yeah,
type
drugs.
of the diet factor what they are eating, major evoke it plays. So there is subclinical insulin resistance which is definitely there in these patients. The hormonal dysregulation is definitely there. The
yeah,
LH of these patients would be very high when compared to obese PCOS patients. That itself would speak volumes on it. So it is
yeah,
much better to address them and tell the patients that even if you are lean, you need to gain weight, and the way to gain a muscle weight would be the exercise and the weight bearing exercise, which has to be done so that you are correcting your PCO patient.
yeah. That is it. I'm just saying on the other side, like, because whenever we tell them, na, it's very difficult to motivate them and make them understand about this. Immediately they'll come to us and say that they are already within their BMIs within normal limits, and their
But
cycles are irregular. But anyhow, definitely we know. But what I mean to say is it is difficult to tackle those type of patients.
ma'am, we
Usually,
have to talk to
obese patients, they are also, we also say, and then they agree to us. We show them the chart, it is there. These are your exercise chart, this is the diet chart, which usually we give to our patients. And then, but about lean patients, they are, it's difficult to make them understand. Yes, definitely, some patients they understand very well, and then they respond also very good.
They don't have
Very
fat.
nice understand.
They may not have fat, therefore they are lean, but they also do not have good muscle mass.
Muscle, yeah.
So they don't realize that. And Dr. Rakhi very rightly pointed
Yes.
out that they have to build their muscle mass.
mass so that the hormones get corrected, and we have got our hormonal figures with us in hand to show them that how bad is your body inside. Even if you're lean, you're not gaining weight, the hormones of your body are
They
really
are not
bad.
appropriate.
The LH is very bad when compared to the obese patients, so you
Yeah.
have to correct that. The way to correct is only the diet chart which has to be followed strictly, the exercise which has to be followed strictly. That is how we go about.
Yeah, this is what.
And the only way that they can decrease their insulin resistance is increasing their quadriceps mass. So
Yes.
all quadriceps exercises will actually improve their PCOS. So they have to do that.
That's
Yeah, I know.
nice
I'm just saying
information.
the tackling of those particular patients are very difficult.
It's difficult, but
So,
yoga and
Not take on
meditation
it.
also
Yeah,
helps. You
right.
have to decrease the stress levels, no?
yeah. That
So
is.
thank you so much. Thank you for those that wonderful discussion and a strong insight, a point take home message to focus on quadriceps.
Yeah.
So that is building the muscle mass.
Muscle mass.
So for the lean PCOS, though they are very difficult to handle. In fact, obese are easier. Lean PCOS are much difficult to handle. So we'll be tackling them later. Now we have another thing to take care of, and that is the panel discussion on RPL. RPL, another important thing which really irritates and which saddens us and the patient as well. So whenever there's recurrent pregnancy loss, we are at a loss to how to improve that and how to help our patients. And for that, we have a fantastic panel now, and another maybe we have an hour or maybe 50 minutes or so, for which we have our experts. Dr. Do we have the slides, Nimisha? We have our experts, Dr. Ruby Bhatia ma'am, who is the President Life Member OBGYN Ambala, and she is the Professor Head MMI MSR Mulana Ambala. Ma'am is an academician. Even in her dreams, she just thinks of teaching, and she has multiple awards. And thank you so much, ma'am, for joining us today. Another thorough academic person and head of department of obs and gynae from the premier institute of Rohtak, which is Postgraduate Institute of Medical Sciences, Dr. Pushpa Daya. So thank you, Dr. Pushpa and Dr. Ruby, for joining as experts for this panel, which will be moderated by Dr. Pooja Thukral. Dr. Pooja is Associate Director, Cloud9 Hospital, Faridabad, has multiple interests in endoscopy, reproductive endocrinology, and cosmetic gynecology. And we have the complete panelists, wonderful panelists that we have from across Delhi, Haryana, Dr. Madanjeet from Gurugram, Dr. Shalini Chawla from Delhi, Dr. Lakshmi Goyal from Faridabad, Dr. Tejashri from Delhi, Gangaram Hospital, Dr. Rakhi Goyal again from Chandigarh, and Dr. Divya Kumar from Faridabad. So we will have to, we'll start so that we don't waste time, and we'll try to utilize the best time that we've been given. Over to Dr. Pooja, please.
Yeah, thank you, Jyoti ma'am, for this kind introduction. Thank you for giving me an opportunity to be in this webinar. And the best part about the webinar is my mentor, Dr. Pushpa Daya, is here. She was my postgraduate guide in Rohtak Medical College, and much more than just a guide. She's been almost like a mother to me. My friends are here. Rakhi, we've studied together. Shalini, we work together in Maulana Azad Medical College. Divya has been a colleague, and Dr. Lakshmi is currently working with me in Cloud9 Hospital. So thank you so much. It was a wonderful constellation of people to moderate. And thank you so much for this opportunity. Without any delay, I'll proceed with the recurrent pregnancy loss presentation. And one by one, I'll be asking all the panelists to answer. And let me just convert it into a slideshow. So we keep this case in mind and then we proceed. This patient, Mrs. P, she's 35 years old. She's 6th gravida with previous 5 abortions. And she had a spontaneous conception. And when she came to me, she had a positive urine pregnancy test. There was no significant past medical history except for the fact that she was taking glycomet, probably started by somebody else before she came to me, but she does not give any history of being PCOD. She had regular menstrual cycles, and that's how obstetric history goes like. First was a spontaneous conception. It was a missed abortion at 6 weeks. She underwent DNA. The second miscarriage, again, it was a spontaneous miscarriage at 6 weeks, which was followed by a DNA. Now that she had previous 2 miscarriages, in the subsequent 3 pregnancies, which were missed at 10, 6, and another at 6 weeks, the patient had received constellation of medications. She had got ecosprin, she got low molecular weight heparin. In all the last 3 miscarriages or last 3 pregnancies, she had also got IV IgG and intralipid injections. And this is how she came to me. All her blood tests, the APLA profile, thyroid, blood sugar levels, everything was normal. So the diagnosis we made was unexplained recurrent pregnancy loss. Directly jumping to the questions, first I would like to ask Dr. Madanjeet, when do you say it's a recurrent pregnancy loss?
Hi, good evening, everyone. We call it recurrent pregnancy loss after 2 consecutive losses. That is the latest. Earlier, it was said we call recurrent pregnancy loss after 3 losses, but after 2 consecutive losses, we are terming it as RPL.
Okay, so most of the slides that I have prepared I have referred to the ESHRI guidelines 2022. And according to the ESHRI guidelines, a diagnosis of recurrent pregnancy loss could be considered after the loss of 2 or more pregnancies. We have a latest RCOG guideline, which also says that recurrent miscarriages has been defined as 3 or more first trimester miscarriages. However, clinicians are encouraged to use clinical discretion to recommend extensive evaluation after 2 or more first trimester miscarriages, if there is a suspicion that the miscarriages are of pathological and not of sporadic nature. So what they're trying to say, ESHRI says 2 or more losses, we call it recurrent pregnancy loss. RCOG says 3 or more losses, but we can start evaluating the patient if the clinician and the patient agrees to go ahead with finding out what's the reason for recurrent pregnancy loss. Dr. Divya, what is the prevalence of recurrent pregnancy loss?
Good evening, all. And coming to the prevalence, it's like almost 1 to 2%. Some studies quote that it's 1 to 2% of the all pregnancies. Or some other studies have also quoted that it's around like 0.8 to 1.4%, if only we consider only clinical miscarriages. Clinical, by clinical, I mean when it is confirmed by ultrasound. So this is the usual prevalence of RPL. And if we consider the additional biochemical losses, then it is around 2%, 2 to 3% of all the pregnancies.
Okay, that's great. So the prevalence of recurrent pregnancy loss is approximately around 1 to 2%. Dr. Shalini, what are the known risk factors of recurrent pregnancy loss? You could just enumerate them.
Yeah. Sure, we can have the known risk factors of pregnancy loss. There are certain factors which are modifiable and there are certain factors which are non-modifiable. Now, coming to like age, we all know that with the increasing age, the incidence of chromosomal aberrations increases, hence the risk of chromosomal abnormalities increases. So, especially after the age of 38 and more so after the age of 40 years, the incidence of abortion rises to as high as 50%. Then there are other lifestyle factors like smoking, alcohol, stress, all those factors, they do lead to increase in the pregnancy or the miscarriages. Now coming to other factors, like in cases of, we can divide those factors as maternal, paternal, embryonic. And in maternal, we can have the uterine factors and the embryonic factors. In uterine factors, we can have like those anatomical causes where they could be congenital anomaly of the uterus like septate, biconjugate, and acquired could be submucous myoma, polyps, and all those malformations. And coming otherwise, then otherwise the embryonic factors could be like genetic factors associated with it. Male factors, certainly it's coming up in a big way that now we know that with increased paternal age also, the incidence of abortion rises, and the other pathologies, especially like autism and all, we are seeing a great increased risk with that. And then we have the coming to rest of the factors, like we have thrombophilias, inherent and which can be acquired also. And then immunological causes, it's still a very gray zone area. A lot of research is coming up in a big way. Then coming to the embryonic, we have the embryonic factors where the mutations or the chromosomal errors occur, or like during the these errors, they do occur during the period of organogenesis, and all this leads to the recurrent abortions. And I still further would like to elaborate that karyotyping, which again itself would be like included a part of the chromosomal disorders, like
We'll talk about it eventually.
Deletions,
We'll talk about it, Dr. Shalini.
Yeah.
Very well enumerated. So certain risk factors where a patient is more likely to have a recurrent pregnancy loss is when she's more than the age of 40. So we tell women the best age to get pregnant is 20 to 35. Stress is associated, but it does not have a causal effect. Like Dr. Pushpa was saying, environmental factors play a role which we tend to ignore, like heavy metals, pesticides, and lack of certain micronutrients. Though we do not have sufficient data to tell us that, we need to tell the mother to avoid certain occupations or to avoid certain environmental exposures. in patients with recurrent pregnancy loss. Chronic endometritis is coming in a big way. One of the reasons to implicate as a cause of recurrent pregnancy loss, a lot of studies are going on. Similarly, low uterine natural killer cell activity is said to be responsible for higher number of miscarriages. Dr. Lakshmi, are there any health behavior modifications which are relevant for reducing the risk of RPL in somebody who presents to you like this patient, the case 1?
Yes, good evening, ma'am. There are many health behavior modifications that can be told to the patient. Like if the patient is into smoking, and then cessation of smoking is, of course, will be very beneficial. Then alcohol consumption is another thing. Lot of intake of caffeine is also is harmful and can lead to recurrent pregnancy loss. Also, the nowadays we see the night shifts and the diurnal variations that happens because of that lead to hormonal imbalances, and sometimes patient can correct it because like the office hours, they can change something like their office timings to such that it is better for their body, and that can also have a better effect in terms of RPL. And then of course the BMI is one of the most important thing that is really beneficial. Normalization of BMI with the help of exercise and diet, and yeah, that these are all many factors which are modifiable, and we should always tell patients to work upon them.
Okay, wonderful.
And I would
Dr.
also like
Lakshmi?
to add in this, Dr.
Yeah.
Pooja.
Sure.
In such situations, I also counsel my patients, to switch off the Wi-Fi's at home and even keep their data of the phones, especially the males, not to
Right.
keep the phone with the data on in their jeans or trousers.
Correct.
So
Okay.
the small things
Yeah.
do make a little improvement.
We do tell them to patients who come to us with subfertility. This is the general advice we tell them, that the husband should not keep the phone in their jeans or the pant pocket. But I could not find any evidence mentioning the use of radiations in patients with recurrent pregnancy loss. So I'm sure that carries relevance here as well. Thank you. That was Dr. Madanjeet, I think.
Yes.
Okay, thank you for adding that. So couples with RPL should be informed that smoking could have had a negative impact on the chances of live birth, and therefore cessation of smoking is recommended. Normal BMI somewhere around 20 to, so around 20 to
23.
25. So more than 25, she'll be overweight, more than 30, she'll be obese. So being underweight and being overweight, and of course
Less than
obesity.
18.
Yeah, less than 18, more than
Is
25,
underweight, yeah,
more than
and
30.
more than 23.
So they should strive to maintain a normal BMI from, say, 20 to 25. And we do not know whether caffeine is a risk factor for recurrent pregnancy loss, but yes, definitely they should limit their caffeine intake to 200 milligrams per day. And we know that they should not take alcohol at all. Dr. Tejashri, now we come to investigations, and how would you like to proceed? This patient, she's got previous 5 miscarriages. She's come to you and she's got certain tests done already. But if she would have just come to you, what were the further tests you want to do? Or let's discuss about all the investigations in RPL.
Yeah, so
one by one.
basically, hi, Dr. Pooja. Thank you for having me here. I would like to, sorry, I missed your investigation part in this woman, but I think she has undergone a lot of first trimester losses, and all of them are first, all of
First
them for being
trimester,
first
correct.
trimester.
Correct.
So, was the POC karyotype done for this patient? That will be the first thing for any of these pregnancies that
Yes,
I would like.
karyotype was done. Yes, karyotype was done.
POC karyotype was
Type was
done.
done. Parental
And
karyotype was done.
yeah, and
Yeah.
parental karyotype was done.
Karyotype
So
was done.
basically, whenever a patient of RPL comes to me, if she's non-pregnant, of course, I would like to investigate her and advise her to get pregnant only after all the relevant investigations have been done. Of course, first of all, I would like to ask history about each and every pregnancy and try to understand what was done in those pregnancies. Was the cardiac activity present or not? At what stage was the pregnancy loss happened? Was the POC genetic evaluation done in the form of whether it was a microarray CGH or what was the investigation that was done, what was the kind of support given, or was the low molecular weight heparin or antithrombotic therapy given to her in any of these pregnancies. So all that relevant history is something I would want to know from that patient.
Absolutely.
Also history of
Absolutely.
DNC, because like you mentioned, chronic endometritis is picking up a lot, and any intervention on the uterus would trigger chronic endometritis, and we would like to scratch our brains and think whether a DNC was done, which could have changed her microbiota. So, a relevant history about her obstetric, obviously her obstetric history, but also her medical history, whether she has any history of sugars being abnormal or thyroid being abnormal in her, previous pregnancies or between those pregnancies, and a family history, which would also suggest that if there is any thing that we are suspecting in the parental karyotype, which could be familial. Very rare though, but it could be there, and that's really
Thrombophilians.
treatable because we can, then advise a genetic counseling and then go ahead with specific targeted treatments. So, of course, all of these would really help us make a diagnosis in our mind that if always her fetal karyotype had been fetal genetic assessment had been normal, if it was done previously, we kind of then think about thrombophilias. So the genetic analysis of the pregnancy tissue really helps us to think. If it was abnormal, that gives us a reason for that pregnancy loss. It may not help us in counseling her about prognosis of the uh, next pregnancies or in the treatment of the next pregnancies, but we would know that lesser chance that she would have a thrombophilia problem if the baby was abnormal. So
Dr.
that really helps.
Tejaswi, when do you want to do a genetic analysis?
So
A patient-
basically,
yeah.
though it is suggested that two pregnancy losses is when we define RPL and go for it, but
Right.
many of the studies have suggested that even in the second loss, you can go for the tissue and genetic analysis, and if that comes normal, then we
Right.
could then work her up for thrombophilias and other
Correct.
tests.
Right.
So
Got it.
that could be done, though it is suggested that after two losses is when we go for it.
Okay, great. Thank you, Dr. Tejaswi. Dr. Rakhi?
One more thing is 3D
Yeah.
ultrasound. I would really like to know about the
Yes.
3D ultrasound of this patient, especially she's undergone DNC, and if there are any synechia or anything inside the uterus which can be dealt with hysteroscopy.
Correct.
And
Perfect.
one more thing I'd
I'll
like to
just
add,
add
history
here.
of COX is also very important, like tuberculosis. Sometimes it also causes recurrent pregnancy losses.
History
Okay.
of consanguinity is also very important with these kind of abortions, because especially in the Muslim community where the consanguinity is very, very common. And coming to that question, when do we get the genetic analysis done? These days patients are Google read so much. Once a patient undergoes even the first abortion, we do need to tell them like these are the tests done, though
They
the
exist.
guidelines
Yeah.
and the recommendation says that they are to be done after two abortions. But at times, the patient can come and question you that why didn't you advise it? So with the proper guidelines, I do agree, but these days patients are real smart. They might question you.
Right.
I know they are not
We are
recommended,
correct. So we're
but
going by
yes,
what the evidence is
Yeah, we
saying.
can always tell them that,
Correct.
that is
Yeah.
not what is
yeah,
suggested, and
Correct.
we should not be doing
yeah.
an intervention like DNC just for,
Yeah.
Correct.
the first
Yesterday I
pregnancy loss,
saw,
because
yesterday only I saw a patient who had gone all the CGHS array also for PUCs right after the first abortion.
yeah.
Sometimes patients are
We
very
don't know
apprehensive.
Yeah.
We can just do a
very
genetic
true.
analysis for explanatory purposes, though it is not
True.
recommended.
Yeah,
And
that is
It
what
can
I'm
similarly,
be for
saying.
explanation. Yeah, correct.
Yeah, that is
similarly
When
what
with
the
I'm
the
age
saying.
of the
You
puja,
need to
patient is
tell them.
like more than 35, then also like we can offer them when she's an elderly, like advanced maternal age, then maybe in the first miscarriage also it
So,
can be done.
yeah, it can be done, but let's go by what the evidence is
Yeah,
saying. Because
definitely,
the purpose of
definitely.
the
Yeah,
panel
true.
is to take
Yeah,
home,
To
the
yeah.
message is to do
Yeah, we can
evidence-based
take a
practice.
comment
Yeah,
from our experts
yeah,
regarding this, since we are
yeah.
we are discussing on this when to do the genetic analysis. Can we take it?
You see,
Yes, absolutely. Yeah, yeah.
hello, Dr. Pooja. What I
Yes,
was
ma'am.
just thinking that the way someone was just asking that whether after the first miscarriage, can we go for this analysis? But I think we should not forget that Usually the first trimester, it is the chromosomal abnormalities are there very early. So after first, we should not go for this, though the patient may say, but as far the literature says, we should not.
Correct. Yeah. Correct.
Yeah, very true. That we agree.
Correct. I
Very
agree.
rightly
Yes.
said.
I would
Yeah.
like to add that RCOG says that do the testing in the third one only for the karyotype and in any second trimester miscarriage, even the first one.
Correct. So basically, if somebody comes to me with a first trimester miscarriage, I would not offer them a genetic analysis of the products of conception. However, if she's come with 2 previous losses, then we can offer it to them. And 3 or more, definitely analysis of the product of conception must be offered to the patient. And for them to do it or not do it is, of course, their choice at the end of the day. Okay, Dr. Rakhi, which genetic test would you want to recommend to your patients?
Now we
For the
do
products
a
of conception.
RACGH.
And why is it done?
Because it reduces the risk of maternal contamination effect. Earlier we were not sure whether it was a maternal contamination. If it came out to be 46XX, then difficult to differentiate from the maternal this. So we do
Perfect.
RACGH now.
So we do a array comparative genomic hybridization, which is the method of choice now in the products of conception. Like Dr. Rakhi said, the chances of maternal contamination, even if it is there, we are able to pick with the CGH, and there is no failure. Like normally when we used to do a karyotyping, there was tissue culture failure, which does not happen with the array CGHS. So this is the test which is being recommended. And nowadays we also have next generation sequencing. We have the exome test, but nowadays it's not recommended to do these tests as a first line option in a patient who comes to us with recurrent pregnancy loss. Maybe when we do this panel again, that will be the first or the second line of investigation. And Dr. Madanji, when do you want to do a parental karyotype? Now we've assessed the POCs, but when do you want to assess the parents? Dr. Madanji? Dr. Divya, you want to take this question? Parental karyotyping? Yeah.
Parental karyotyping should be done when there is a definitive history of congenital malformed baby from the same couple. Then usually we advise parental karyotyping.
Correct. Or if there are unbalanced chromosome abnormalities in the family, or if there's a translocation defect which has been picked on the POC tissue.
And there is one more indication if the previous products of conception are not available or have never been tested.
Perfect.
Then
Perfect. Correct. Now, Dr. Shali, do you want to do a thrombophilia screening in somebody who's had previous 5 miscarriages, like in this patient?
Yeah, certainly, Pooja. I would like to get the thrombophilia screening done. Now, as per the standard guidelines, it is recommended to go in for the acquired thrombophilia test, like the lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein. Now, for the congenital or the inherited thrombophilias, they are recommended more so when there are second trimester losses, when there is an additional family history of, like, say, venous thrombosis or some stroke or maybe some kind of event, then only the acquired tests, like for the this factor C, factor S, and antithrombin 3 and factor 5 lead-in mutation, and this MTHFR gene. So as of now, I think going with the standard practice guidelines, tests for the acquired thrombophilias are more suggested.
Okay, so the recommendations are somebody with previous recurrent or somebody with recurrent pregnancy losses, we must not do the congenital thrombophilia screening, which is mutation in prothrombin gene, mutation in factor 5 leading, protein C, S, and antithrombin deficiency. We would do these tests only if the patient herself gives a history of having any thromboembolism episode or there's a family history suggestive of thrombophilia. Otherwise, we should not be doing the thrombophilia tests in them. We should not be doing the MTHFR mutation in them. The only thing we screen them for is the secondary thrombophilias, which is the antiphospholipid antibody syndrome. Now, Dr. Lakshmi, which are the tests that you would like to do? The acquired thrombophilias. What is recommended?
Ma'am, recommended for acquired thrombophilia, as Dr. Shalini has already told, a lupus anticoagulant, anticardiolipin antibody IgG, IgM, and anti-beta-2 glycoprotein IgG and IgM.
Perfect. Great. Dr. Tejashree, what is the value of immunological screening in the diagnosis of RPL?
So as per the current guidelines, they do not suggest us to do any kind of immunological evaluation in the form of HLA or cytokine testing. ANA is something which could be considered as per the recent update of 2022. But there is, again, insufficient evidence about uterine natural killer cells or peripheral natural killer cells as well. So we can order, we could, consider if, like in your patient, probably we couldn't find any of the genetic cause or thrombophilia profile was normal. So I think in such patients, we can order a ANA wherein it's an unexplained RPL where immunology seems to be one of the reason which could be there. So we can consider anti-nuclear antibody testing, but all other tests are not suggested as per the recent update.
Okay, that's perfect. What is the value of screening for metabolic or endocrinological abnormalities in diagnosis of RPL, Dr. Rakhi?
Only the screening for thyroid by doing a TSH or TPO antibodies is recommended. Otherwise, no other testing for PCOS, insulin, fasting glucose is not recommended. Prolactin testing only if the patient has some symptoms like oligo or amenorrhea or galactorrhea. And ovarian reserve testing is also not indicated. So only thyroid screening.
Perfect. So
is
it's both
Dr. Pooja,
TSH.
though,
Yes.
I would like to add here that since we are, talking about Indian population, these guidelines are all European. And
Correct.
for our country, diabetes is something which is, universal thing, could be running in the families a lot.
Correct.
And as a race, we are prone to diabetes. So though the
Correct.
guideline doesn't mention, but we would certainly like to screen this woman for her sugars.
Absolutely. I agree with you. Yes.
And basically all PCOS patients, so we rule out diabetes and pre-diabetic. So yeah, I agree with her that we rule out diabetes, but in the guidelines, it is not recommended.
Correct.
And
Correct.
no other
But
further
considering-
testing
yes.
for androgens or luteal phase deficiency. So these are all not recommended.
What
Or
about
for
luteal phase
homocysteine
deficiency?
levels and all
Correct.
plasma levels, these are not recommended.
Okay. And what is one thing which they say you can do? Like
Testing?
vitamin D. Vitamin D.
Vitamin D testing is not recommended, but we can do a
Supplements.
supplementation in the preconception
Supplementation
period.
can be given during the preconceptional period.
Not testing is not in the
Correct.
recommendations.
Correct. Then we go to Dr. Madanji. Dr.
Test
Madanji, are you
vitamin.
here?
Yeah,
If
I'm
you
here.
test
I'm here.
Okay.
That time I just was on the way, so I
Oh.
disconnected. Yeah.
No worries. Somebody mentioned that we must evaluate the anatomy, the uterine anatomy in somebody who has recurrent pregnancy loss. So what is your choice of investigation, Dr. Madanjeet, when you want to evaluate the anatomy of the patient who has RPL?
See,
Yeah.
non-invasive would be the best as a 3D ultrasound,
Correct.
transvaginal.
Correct.
And in amongst invasive, it would be the sonosalpingography.
Correct. Next would be, if suppose you don't have sonosalpingography available.
A simple HSG.
Correct. And something else? Suppose if
MRI
a
can also be
2D,
offered.
2D scan is sometimes where you don't have 3D TVS. 2D TVS is also good enough.
2D is usually for adenomyosis. Like, if you're
Correct.
suspecting adenomyosis as one of the suspicion for recurrent pregnancy losses.
Correct. So
In fact,
that was,
may
yeah.
I add?
Sure,
Yeah.
sure.
Yeah, see, because sonosalpingography and HSD, certainly they are invasive tests, though these guidelines might say that, but considering the Indian scenario, I think my choice would be like first an ultrasound, 3D or a 2D. If not, then probably we can consider an MRI over HSD or SSD.
But the two,
Because because these tests are really invasive. The patients who have got these tests done, the HSG or the SSG, they really say that they are real painful tests.
Yeah, but the cost of MRI, everybody
Yeah.
may not want to do a
Yes, yeah.
MRI because of the cost involved. So the indication of MRI would be probably if you suspect that there could
Mullerian
be
or
Mullerian
associated
anomaly.
renal,
Yeah,
Correct.
renal associated renal anomalies
So if there is
along
a
with the
suspicion of
Mullerian
any
one.
Mullerian anomaly, then you want to screen
Then
and look at the
only.
kidneys. Yeah, you want to look at the kidneys and the ureter of the patient. So all women with RPL should have an assessment of the uterine anatomy for sure. The preferred technique is the transvaginal 3D ultrasound. Why? Because it has a high sensitivity and specificity, and it can distinguish between a septate and a bicornuate uterus. A sonohystrography is more accurate than HSG, and it can also be used to evaluate the uterine morphology, plus you can see the tubal patency. And like we said, if there is a Mullerian anomaly, then you may consider doing a MRI. Otherwise, it's not the first line option. And like somebody said, that 2D ultrasound to evaluate for adenomyosis. Then, Dr. Divya, does the quality of male gametes contribute to RPL?
Yes, recent studies, they prove that even the quality of the sperm, so that definitely affects the, with a lot of free radicals in the environment. So definitely DNA fragmentation can help. It can give a direction and about the quality of the sperms also. And because of stressful lifestyle, environment, pollutions in the environment, like stress, we have already talked about smoking, alcohol and all. So they can definitely affect the quality of the sperm, and the quality of the sperm can affect can be a cause of recurrent pregnancy loss, and in which DNA fragmentation, definitely we can do a test for DNA fragmentation. And if
we
it is,
advise, yeah,
yeah,
the
we can
about-
advise, and we do have something for it, like we can give antioxidant, we can go for a
So we
change
talk
in
about that
lifestyle.
later. Yeah.
Yeah.
Now we come to the treatment modalities. Dr. Shalini.
Yeah.
The treatment, we just list them and we'll talk about them individually.
Yeah. So coming to the treatment modalities, that basically depends upon the cause. If we are able to find it out, like suppose there is an anatomical defect, then we try to correct it, especially the septate uterus. We do try to correct it, which is in fact the commonest anomaly. And if there is a thrombophilia deficiency or the thrombophilia screen is positive, we do like to add the low molecular weight heparin and the ecoscrin. And if there is some endocrinological disorder like thyroid abnormality, we do like to correct it. Or if there is a diabetes, then we do like to correct it. And maybe even these days, there's a lot of role coming up of the anti-TPO antibodies. So the guideline says that if the patient is euthyroid, but anti-TPO antibodies, we still can avoid it. But yes, if along with the hypothyroidism and anti-TPO antibodies are there, then probably levothyroxine is suggested. Along with that, progesterone is, I think it's everybody's favorite for all of us. As soon as the patient conceives, we do like to add progesterone to correct any luteal phase deficiency if we have. And coming to the other, probably yes, vitamin D, folic acid, and pyridoxine, definitely we do like to add it. I think that covers. And if the patient is PCOS, metformin, I still would put it as a question mark. Maybe yes, if she has recurrent abortions and she is PCOS, then no harm in adding metformin also.
Okay, thank you. Dr. Shalini, Dr. Lakshmi, what is the evidence of using anticoagulants in women with recurrent pregnancy loss with thrombophilia and without thrombophilia? What does the guideline say? And in those who are APLA positive?
And the guideline says that without any evidence of thrombophilias or APLA positive, we should not use.
No, APLA
but
positive?
No, if
Yeah, we
without
should.
any, if
Yeah.
it is not positive,
Yeah.
if there is no evidence that, if there is no investigations that are suggestive of thrombophilias, just on the basis of history, the guideline says no, we should not use. But
even if she has thrombophilia?
no,
No,
if she
then we
has,
can use.
If she has, then we should use. But if there is no, just on the basis of 2 pregnancy loss, previous losses or missed abortion, and no other history or no other test positive, then we should not use. The guideline says that.
Okay.
But
So, yeah. So first we are saying she has hereditary thrombophilia. So do you want to use?
yes, then we want to use.
We suggest not to use. The guideline says we suggest not to use antithrombotic prophylaxis unless it's in the context of research or if indicated for VTE prevention. So she has hereditary thrombophilia, but still
Right.
we are using it for her personal protection if she's at a risk of thromboembolism or if it is a study where we are a part of a research.
Right.
Right.
But we always use, ma'am. That's the another thing. Right.
Yeah,
We do a lot of things. We do a lot
Yeah.
of things. Yes, I agree with
Yeah.
you.
Yeah.
It is not
I mean,
Well, on the
after
basis
2
of
abortions, or
yes.
I agree. I agree.
Dr.
Right.
Pooja, just one point here I wanted to highlight before we go for the treatment. Whenever we order the tests for thrombophilia, we have to be sure that she's at least 6 weeks
Correct.
after the last abortion.
Correct.
That is one point
Correct.
we must highlight,
Absolutely.
because
Yes.
Yeah. True.
otherwise the tests might be affected. If
Yes, I've
she's
seen a lot
because
of
of it.
people recommending the
Yes,
test while the patient is pregnant.
immediately. While, yeah,
Yeah.
correct.
So the
So, like,
results may be
that's one
biased.
important thing that we should keep in mind, that we have to wait patiently for 6 weeks after the last loss to order the
And
test.
plus we need to do 2 tests 12 weeks apart.
Ideally.
Yes. Yes. Only
Yeah.
then
But
we
they're
can
so
say that the patient.
expensive.
Correct.
Yes.
Correct. I agree.
But we can do the second if the first comes positive. If the first is negative, we can skip it
Absolutely.
to be done after 12 weeks probably.
Absolutely. So Dr. Lakshmi, now we're talking about APS,
Right.
antiphospholipid. Yes.
Right. So in for antiphospholipid syndrome, it is recommended to administer prophylactic dose of heparin, that is low molecular weight, which we give starting from the positive pregnancy test. Normally, the recommendation says once we have the heartbeat, fetal heart rate present, then we should start in the dose of 40 milligram subcutaneously daily. And also, we can add aspirin 75 milligram or 150 milligram, depending upon the BMI of the patient.
Right. So the guidelines say we start at the date of positive pregnancy test.
Yes, yes.
Okay.
And the
And,
dose
and
is
for
like
3 or more
60.
pregnancy losses.
And for positive APS, isn't it the dose is 60 milligram?
No, it doesn't specify. It's 75 to 100 milligram.
No, I'm
no,
talking
no.
about low molecular weight heparin. Is it 60 or 40?
Depends
The
on the
dose.
BMI.
Yeah.
It depends on the
BMI.
BMI of the patient.
Okay.
Yeah.
Dr. Pooja, I would like to ask a question from all the
Yes.
panelists and the experts. What is their opinion regarding treating non-criteria obstetric APS, the new guidelines which came in 2023?
They say that 2 or more pregnancy losses.
They have clinical and lab criteria, and then numbering is there. So
Actually, there is a concept of seronegative, APLA positive.
Yeah, they have many categories. They
criteria
are
to
divided
diagnose
that
that.
partially fulfill
Yes.
the clinical or the lab criteria or low seropositivity. Because
Correct.
some
Or
of the
other
studies say
antibodies
that
like IgA could be positive. If the IgG, IgM is negative, IgA also could be positive.
IgA is not included, but IgM, IgG in low titers, like less than 40 or persistently there, or don't
Yeah.
fit into the criteria of these 3 losses, maybe 2
Yes, so
first
there
trimester
is a
losses.
lot of thing coming up about seronegative, APLA positive, and
Seronegative,
so,
they have
and
3-4
clinical
categories
positive.
are there. One is seronegative, one is like partially clinically positive.
Yes.
So some of the studies now say that they also fare worse compared to those who don't have any criteria. So whether we need to treat them or do you clinically treat them or not? Dr. Pushpa ma'am, if you have any opinion regarding that.
Yeah. Hello. So, what is definitely the clinical criteria and lab criteria we need to consider whenever we are deciding for the diagnosis. So, in the lab also, it is when anticardiolipin antibodies, IgG, IgM in medium to high titers, and when they are being taken 12 weeks apart. This is also one of the criteria for the lab. Lupus anticoagulant coagulant also, which is twice, it has to be done at least 12 weeks apart, and the same with the anti-beta 2 glycoprotein in medium to high titers when it is there 12 weeks apart. So these are the lab criteria which we need to consider when we have to take the treatment into action.
I was talking about the new Euler criteria which came in, I think, 2023.
I think it is in this RCOG, this green top guideline, it is the same.
RCOG does not follow this. RCOG is, they are referring to that Sydney classification only of the APS, the Sapporo and then the modified. But the other one also came in 2023, which has different on the basis of this non-criteria APS, obstetric APS treatment. Chalo, we can move ahead.
Yeah.
We have not read about it.
Yeah, I'm also not aware, Rakhi, sorry.
I think I am not aware about this. I have not read. I think this is a good question. I think we can just find out again.
I'll
Dr.
share the
Pooja,
references
yes,
in the
ma'am.
group.
We'll just go through and then we can, in this particular group only, we'll add on.
Sure, sure. Definitely, ma'am. Right.
This is for the benefit of all of us.
Okay, great. Dr. Lakshmi, which one would you prefer, low molecular weight heparin or unfractionated heparin, and why?
Low molecular weight heparin is the preferred one because of the lower risk of osteoporosis, and also heparin-induced thrombocytopenia is there with the unfractionated one.
Correct. Plus, you don't need to monitor PT, APTT with the low molecular weight heparin or the anti-10A. Okay, Dr. Tejashri, what is the rationale for the use of steroids?
So basically, immunomodulation could be one of the rationale for using the steroids, but there is no evidence found for use of steroids in cases of RPL. So I have never personally used steroids in any of the RPL cases, but people are trying to study whether there could be any role, and the guidelines also suggest very strongly that there is no recommendation on use of steroids in such cases.
Yes.
There have been certain studies in which they have used steroids. The same ESHRE guideline mentions that they have used steroids in the dose of 20 milligram thrice a day for 6 weeks, and then they've tapered it down to 10 milligram and then eventually to 5 milligram. So that's what the guidelines say. Some of the studies have used it, though it is not, we don't have any RCT for it, but steroids have been used. In this particular patient, I did use steroids because everything had been tried for her. And now today she's 22 weeks pregnant. I don't know what was the reason. I did not follow evidence-based practice, but this was one thing which she had not got in her previous pregnancies.
And for how long? If steroids you want to give them for how long?
So I completely tapered it off.
Which steroid did you use?
I used prednisolone, but I did not use in such high doses. I just used it 10 milligram per day, like for the initial 4 weeks, and then I made it alternate days, and then twice a week, and tapered it. By second trimester, she was done with her steroids.
So she's off steroids now?
She's off steroids now, yes. Yes. So I'm not saying use steroids, but this was one thing.
But that is one tool, like.
Yes, yes. So steroids have been evaluated as a treatment for women with RPL in presence of anti-phospholipid antibodies. And in 2 RCTs, no evidence was found for a benefit of prednisolone combined with aspirin in comparison to placebo or aspirin alone in reducing pregnancy loss in women with RPL. We know the adverse outcomes. There is a chance of premature delivery, admission to NICU. There is a risk of preeclampsia and hypertension, and the mother developing gestational diabetes and baby having low birth weight. Dr. Rakhi, what's the role of IV IgG?
IVIGs, there's no studies regarding use in hereditary thrombophilias. In cases of those who were diagnosed with antiphospholipid antibodies, they did not work. They did not reduce the chance of pregnancy loss. In small studies in SLE patient, it was found superior to prednisolone regarding increasing the live birth rate, in number of miscarriages, preterm delivery. And it has been found that in if there are 4 or more unexplained RPL, very high doses, there is only one RCT, but it was found to be high quality. So they said that in very early pregnancy, high doses repeated IVIG, it increased the live birth rate significantly.
Yeah, correct.
So,
yeah.
But there is only one study.
Correct. 400 units per kilogram for consecutive 5 days.
Yeah.
As soon as she conceives. Yes. So it's not recommended to use intravenous immunoglobulin. The only condition where it was used was in women who had SELE and those who've had 4 or more pregnancy losses. Only in those conditions it's recommended to use intravenous immunoglobulin. The use of repeated and high doses in very early pregnancy may improve live birth, like Dr. Rakhi said. What about HCQ, Dr. Madanjeet?
Yeah, HCQS also has got a good immunomodulatory effect and it is being used, and I also personally use it quite a bit. Especially after COVID also. We realized that HCQS has got a lot of immunomodulation properties. So it is recommended also, I think. I'm not sure about ESHRE guidelines, but I am in my clinical practice using HCQS in recurrent pregnancy losses and quite a bit successful also.
Yeah, so the guideline doesn't recommend it, though even in this patient, I did use HCQS in the dose of 200 milligram per day, and it is to be stopped in the second trimester of pregnancy, unless and until she's using it for any
Like
pre-existing,
arthritis or
correct,
something,
like
yeah.
SLE or any other pre-existing
Any
disease.
arthritis.
Correct, correct. Now, Dr. Divya, do you want to treat overt subclinical hypothyroidism?
For like as far as it is associated with recurrent pregnancy loss, I will definitely like to treat any subclinical hypothyroidism.
Overt, we know it
But
has to be treated. Now, what is your take on
yeah,
subclinical hypothyroidism, TPO antibody positive, TPO antibody
TPO
negative?
positive, definitely it should be treated. But if
If the
there's
patient is
no,
euthyroid, okay, so patient is subclinical and
but
TPO.
then you have to keep it like within the limits. Like the TSH has to be around 2.5, the
Less than
recommended
2.5.
limit. Yeah, less than 2.5. So
Okay, so overt thyroidism, we are treating. Patient is subclinical, TPO antibody positive, we are treating. If
treating,
patient
yeah.
is euthyroid, but TPO antibody positive, then there is no recommendation to treat it. Overt hypothyroidism arising before conception or during early gestation should be treated with levothyroxine in women with RPL. There is a conflicting evidence regarding treatment effect of levothyroxine for women with subclinical hypothyroidism and RPL. Treatment of women with subclinical hypothyroidism may reduce the risk of miscarriage, but the potential benefit of treatment should be balanced against the risk. Why? Because levothyroxine has its own side effects. They say that if we are overusing it, there's a potential risk of adverse child neurodevelopment outcomes, since high maternal free thyroxine concentration during pregnancy are reported to be associated with lower child IQ and lower gray matter and cortex volume. Euthyroid women with thyroid antibodies and RPL should not be treated with levothyroxine. The RCOG guideline also says the same thing. Dr. Shalini, what's the role of progesterone? I think you spoke about the role of progesterone and you said everybody wants to use it. What is the recommendation? What is the dose? How would you like to prescribe? Suppose the same patient. Dr. Shalini? Dr. Lakshmi?
I think
Am I audible?
Dr. Pooja,
Yes,
the
ma'am.
vaginal progesterone, I think it has to be given if there is a history of bleeding is there.
Correct, ma'am.
And then 400 milligram twice a day, it has to be given.
Correct, ma'am.
Maybe
No,
till 16 weeks of pregnancy.
Correct.
Is it?
Yes, ma'am, that's right.
Yeah.
So the vaginal progesterone during early pregnancy must be started less than 12 weeks. And somebody who has 3 or more previous losses and has a history of bleeding in the current pregnancy.
Yeah.
And the recommended dose is 400 milligram twice a day. And they say it's to be continued till 16 completed weeks. Though we continue to give it to her like forever, but they say till 16 completed week. Role of HCG injections, anybody can take it?
I would like to add, Pooja, that
Yes.
FIGO guidelines say that they recommend for early role of progesterone in early pregnancy, recurrent pregnancy loss. They say you can use oral dydrogesterone also. Weak recommendation.
They're saying we need more RCTs for this. In fact, they say you start dydrogesterone in the previous cycle, in the luteal phase of.
No, not in the previous cycle, during the pregnancy.
Yes.
No,
I
there
think
are studies.
Recommendation.
There are studies. Yeah.
RCOG and ESHRE say only for threatened abortion when the patient has come during the present pregnancy with bleeding.
Correct.
And FIGO says before the bleeding in the pregnancy you can give, but
Correct.
not during the previous during the luteal phase. For vaginal and rectal and intramuscular, they don't recommend. It's a weak recommendation for oral dydrogesterone.
Correct. We need more RCTs before we
Yeah,
recommend
I
oral
agree.
dydrogesterone.
Yeah.
Role of HCG injections, anybody? Do you want to give HCG injections to your patient with
No.
RPL?
No,
No,
no.
generally we don't give.
Okay.
Yeah.
Okay. So results on HCG as a treatment for RPL show positive effect of treatment on miscarriage rate. However, studies are considered too limited to recommend the use of HCG in women with RPL and luteal phase insufficiency. What about metformin? I think we already spoke about it. Metformin. Dr. Tejashree?
I think Tejashree has left. She had some emergency.
Rakhi?
I would not give in the absence of any evidence, because though in patients with this
Signal is
GDM and diabetic
thing is
patients
being
also,
addressed to me. I'm sorry,
endocrinologists say
but
there are some effects on the baby and the long-term health of the baby, or the birth weight, and all this is affected. So unless if we have given a metformin only for the purpose of this PCOS for ovulation and all, then I would stop during pregnancy. But if she is a case of diabetes, known diabetes, then only I would continue.
so
During
if
pregnancy.
Sorry? Indirect evidence could support the use of metformin treatment to increase the live birth rate in women with PCOS. But in the absence of any substantial studies in women with RPL PCOS, the guideline development group decided metformin is not recommended. So this particular patient that we spoke about, she was already on metformin, glycomet 500 milligram twice a day. I did not stop it. The patient even currently is taking glycomet. She does not have a history of PCOD. Now she's 22 weeks and I did a glucose tolerance test for her, the 75 GCT, and her GCT was 245. So we took a physician
metformin, with metformin, it was
yes, with metformin, it was
then
245.
so she's like she's GDM only now.
Yeah.
Yes. Probably I thought that she had taken steroids also. Those steroids was stopped like almost 1 month back. But now she's just been put on diet. We took a physician reference. Her HbA1c was I think 5.5, 5.6. So we're just putting on our diet as of now and we'll reevaluate her after 2 weeks.
So these high values of glucose must be because of steroid only then? If you are saying she was on steroid? Because
But
HbA1c is within
steroid was
normal.
stopped.
Ma'am, I stopped steroid almost, I
She
think,
might have
6
developed
weeks back.
GDM also. Like
Could be
1 month
because I
back.
don't know. Yes,
Okay.
ma'am. She's
It's okay.
22 weeks pregnant now.
Okay.
I think I
But
stopped
what
it
I've
around.
seen, Dr. Pooja, of the
Yes, ma'am.
like in the practice, the patients who are already on this metformin, and if they conceive PCOS patients,
Yes,
so
ma'am.
usually they want to continue the metformin
Correct.
for a long, because otherwise the chances, the way the certain studies also say, the incidence there is of live birth is comparatively more if they keep on taking this metformin.
Correct.
So
Maybe like
only in
certain
patients with
studies are there.
PCOD.
Yes, this is what I'm saying. Because I think Dr.
Only
Rakhi
with
was saying that she
PCOD.
would like to stop. That's why I was just thinking, Dr. Rakhi, I don't know, in your practice, are you stopping?
Ma'am,
Because
the
sometimes
thing
what
is, with the endocrinologists say that with the use of metformin, there are increased chances of preterm birth and the birth weight is slightly reduced, and there are some long-term consequences about offspring being overweight also.
Okay.
So we have to see insulin is the best if you have to give for this control of any GDM or diabetes, but still they do give a combination, and first preference is for metformin only. So I was thinking from that aspect also, that what are the effects of metformin on the baby. And so this is
As
that
such,
is
nowadays we are using metformin. There is no reason to stop metformin in pregnancy. There has been no increased risk of any congenital malformation in the baby.
No, not congenital malformations. The increased chances of preterm birth weight is
That is true.
reduced.
Some studies do say that. Correct.
No, they say it.
I agree. I'm agreeing with you. But nowadays, that's the first line of treatment for management of GDM. First metformin, and then they start.
I'm saying they use it, everybody uses it.
Correct.
So they say that you have to explain to the patients that along with the metformin, these things can happen. especially when the patient is refusing insulin even after counseling and they don't want to continue with metformin. Patient have this myths also. Then once we start on insulin, we have to take it lifelong.
Correct.
And they refuse it also.
Okay.
So I think we should think holistically about it, not only about the recurrent pregnancy loss part and the offspring and the later or long-term health of the baby also, when thinking about adding the treatments. So only for the purpose of PCOS, if we have given metformin, initially we have to judge and see why we have added the metformin before conception and whether it should be continued during pregnancy or not.
Okay. I would continue metformin if the patient is PCOD and she conceives. Rest, my experts would say, and the other panelists also.
I'll also continue. We usually continue. If the patient is having PCOD, she's on metformin, we'll like to continue.
Yeah, it has to be continued. Usually, I also do the same. If a patient she's already on PCOS patient on metformin, we will continue it.
Perfect. Thank you. But yes, whatever you said, Rakhi, is valid, and we take your point. Thank you for adding that. Yeah. Is there a role of controlled ovarian stimulation, Dr. Shalini?
Yeah, so Pooja, if we have some evidence where we have to take the patient for pre-implantation genetic testing, either for aneuploidy or for monogenetic disorders, then only there is a role that we are doing IVF for the patient. Otherwise, I don't think so there is any role that we stimulate the patient, because the problem is not that she's not conceiving. The problem is that she's not retaining. So I feel only in those indications I would like to stimulate.
Okay. So the guideline development group decided that the evidence was too limited to support recommending controlled ovarian stimulation in women with RPL, but without PCOS. Bromocriptine, capcholine for hyperprolactinemia?
Yes, if they have, otherwise not as empirical treatment.
Right. Because they say we should not be testing for prolactin unless the woman has oligomenorrhea. So,
or galactoria.
Galactoria. Yeah. But if it is found to be high, then of course we treat it.
We should treat it.
Yes. Vitamin D, like we said, that preconception counseling in women with RPL could include a general advice to consider prophylactic vitamin D supplementation. And the safe dose is up to 4,000 units per day during pregnancy or lactation. What about hyperhomocystinemia, Dr. Lakshmi?
Hyperhomocysteine, normally we don't test in all the patients.
For it, yeah.
Correct.
We don't normally test. We give the L-methyl folate, which is the active form of folic acid, and especially in cases of RPL patients.
Correct. If
and
a patient
B6 and B12 also, right?
Yeah, has found to have had hyperhomocystinemia, then we give a combination of folic acid, active form of folic acid, pyridoxine, B12, and there are some studies which also recommend low molecular weight heparin for the treatment of hyperhomocystinemia. Though we are not testing a patient for hyperhomocystinemia, somebody who's come to us with recurrent pregnancy loss. Uterine malformation, I think Dr. Shalini did speak about it. We'll just go through what the guidelines, it's almost 6:15. Only one small RCT showed no benefit of using hysteroscopic septum resection to reduce. So it was only one RCT which said that don't use it. Most of the studies found benefit of treating uterine septum. Metroplasty is not recommended for either bicarboate or didelphate or for the unicornate uterus. That's what the guidelines are saying. There's a recent data from the TRUST trial which says that treating septate uterus did not improve any live birth rate. And this was the latest study, 2021. And there was a similar study which again said that when we compared patients who underwent septum resection with those who underwent expectant management, there was no benefit of treating patients who had uterine septum. In the event of irreparable anatomic uterine abnormality in RPL, IVF with transfer of embryos to an appropriately selected gestational carrier, if permitted by the local regulations, can be an option. What about treating fibroids and polyps? Dr. Rakhi?
There is insufficient evidence to support this, but though in our clinical practice we do remove it. Particularly if the patient has a associated secondary infertility. So
submucosal fibroids.
But the evidence does not support it.
Right. Insufficient evidence supporting hysteroscopic removal of submucosal fibroids or polyps in women, endometrial polyps in women with RPL. Surgical removal of intrauterine fibroids is not recommended. There is insufficient evidence to recommend removing fibroids that distort. The evidence is saying not to remove it. What about intrauterine adhesions? Dr. Rakhi?
Same, we will treat it, because generally if the patient has a sufficient degree of intrauterine adhesions, they will have this oligo scanty menses, or maybe they might be completely amenorrheic also, and they will land up in a secondary infertility also. So insufficient evidence, but still we like to treat this intrauterine adhesions. And I've seen patients conceiving also, patients of RPL repeated DNCs, and like they came to me for IVF, but before that we did a hysteroscopic adhesiolysis, and they had a spontaneous conception also.
Correct.
I
So
would
the
like to treat them.
Okay, so the guidance is saying that there's insufficient evidence of benefit for surgical removal of intrauterine adhesions, because after adhesion removal, we also have to make sure that the adhesions don't recur. But the only place where they say we must treat is when there are severe adhesions and the patient is having pain, and where the benefit outweighs the harm of the surgery. Then cervical insufficiency. Dr. Madanjeet?
Yeah. Regarding cervical insufficiency, we have to, serially keep her under surveillance regarding the cervical length and give her vaginal progesterone supports. But if there is any previous history of mid-trimester miscarriage, then we do give her a prophylactic encerclage.
Perfect. So women with singleton pregnancy and a history of recurrent second trimester pregnancy loss attributable to cervical weakness, a cerclage should be considered, though there is no evidence that it increases the perinatal survival. What about the male factor? Dr. Shalini?
Yeah. So male factor, I think if you're talking about the sperm DNA fragmentation test, Pooja,
No, we're
if the
talking about treatment now. Yeah.
Okay, yeah. So that is what I'm coming to the treatment also. So if suppose the male partner has high DNA fragmentation, high sperm DNA fragmentation,
Correct.
then we can advise antioxidants to the male partner because they help in overcoming the free oxygen radicals. And certain lifestyle factors that we have to tell them, avoid smoking, alcohol, all those
Correct.
factors, and obesity, correct on
Correct.
that.
Okay, that's perfect. So we should advise them if the DNA fragmentation index is high. Of course, like you said, cessation of smoking, maintain a normal body weight, limit alcohol consumption. And they also have to watch their exercise. They have to stop excessive exercising.
Yeah.
There is no evidence to recommend Baxi in couple with RPL. And antioxidants evidence says have not been shown to improve the chance of live birth. Do you want to use lit therapy,
No.
Dr. Divya?
No.
So lit therapy?
It's not recommended.
Not recommended, correct. GCSF?
Not recommended for RPL.
Endometrial scratching?
Not recommended for RPL.
Okay, great. So we just summarize. Thank you so much, panelists, for your active participation. Thank you, Dr. Pushpa, for your expert comments. And if you just want to take away some things with us after this panel discussion is that we start evaluating a patient with recurrent pregnancy loss once she's had 2 losses. And the test which are recommended is the antiphospholipid antibody, the lupus anticoagulant, and the
Cardiolipin antibodies.
Cardiolipin antibodies. Anticardiolipin, anti-IgM, IgG. We do check them for TSH, anti-TPO. We do and 3D ultrasound to look for any uterine anomalies. If APLA positive, we treat them with aspirin, low molecular weight heparin, thyroxine for overt hypothyroidism, and surgery for uterine abnormalities. I'm so sorry. We discussed about those tests that can be considered for explanatory purposes are genetic tests, immunological tests like HLA-ANA, sperm DNA fragmentation, and screen for hereditary thrombophilia. If there is something which turns out to be positive in the genetic test, we send them for counseling and give them appropriate counseling regarding the PGT options which are available for them. And if they are ANA positive or HLA, we don't have any specific treatment. We discussed about lifestyle advice for those who have positive DNA fragmentation. The tests which are not recommended are immunological test and metabolic or hormonal test. Of course, like we say, tender loving care is a must, lifestyle absolutely required, and prophylactic vitamin D is recommended. So thank you so much, everybody, for your patient hearing, staying for so long till the end of the session.
Thank you so much, Dr.
Thank
Pooja.
you.
You have taken the very difficult and RPL, which is a very emotionally disturbing, traumatic condition for the mother and the whole family, in a very good way. Starting from the incidents till the management, step by step, she has made the things clear to everyone. So thank you so much, Dr. Pooja and all the panelists. And special thanks to Dr. Jyoti for giving me an opportunity to see me all and my loving colleague Pooja Thukral. I really love from the bottom of my heart to Pooja. She's a lovely girl.
So sweet. Thank you.
She did the panel in a very nice way. God bless you, beta.
Thank you so much, ma'am.
Thank you,
so
Dr.
much.
Pushpa.
Thank you, Dr. Pooja.
Ma'am,
Thank you
see,
so
Thank
much.
you.
you love
Thank you,
all of
everyone.
us. You not only love Puja, you love all of us.
Yes, yes, yes.
And
I love, but
especially Puja is a super. I mean, definitely, I had heard her this panel, and that is why I wanted it, because it was a physical meeting where not many people were there, where we had done this panel in Faridabad, and I
yeah,
wanted her to redo it because she had done an excellent work there. And I didn't want her to just limit herself to Faridabad. I thought let everybody listen to this because it is very schematical. I mean,
yeah,
very from basic, from investigation to treatment and the evidence.
yeah.
How, whether with the evidence and how clinically what we are doing. So we have discussed each and everything in detail, and especially Dr. Rakhi has brought up 2 points about metformin, whether we should be using
I'll
it,
be sharing the references in the group, ma'am.
and the
Yeah,
other
Both of them.
some non-criteria on
APLA
that.
criteria. APLA.
So these two new things that we have to again sort of start thinking about, and we should learn about it and know what exactly the evidence states. And thank you, Dr. Madanji, Dr. Shalini, Dr. Lakshmi, Dr. Tejashri, Dr. Rakhi, and Dr. Divya for your excellent inputs. Wonderful panel. I'm sure all the people who have attended definitely must have got their concepts very clear. Thank you, Dr. Pushpa, for your comments.
It's my pleasure.
I would
Our
also
pleasure, Dr. Jyoti.
Yeah, you
Thanks.
gave
Very
my
well
opportunity
conducted
to see
panel, I
two of
must say
our
that.
Dr.
Dr.
Pooja Rakhi
Pooja.
Bukhar from Rohtak.
Yeah, kudos to you. Very well done.
Yeah,
Thank you so
very
much,
nice.
Dr. Jyoti.
Thanks, Dr. Jyoti, for
Thank
giving
you.
us this pleasure.
wonderful speakers that we had, Dr. Pratik on genetic and immunological causes of RIF that we could understand. PCOS, again, the difficult part Dr. Rakhi Singh covered. And I would like to also thank the chairpersons who specially gave their inputs. So thank you so much, each one of you who was there today with us, all the participants. And thank you, Jagsonpal. Over to you, Nimisha. Thank you.
Thank you.
Yes, ma'am. So thank you everyone for
Thank
joining
you,
in
Dr.
today.
Jyoti.
So the session today was brought to you by Jagsonpal Pharma, the makers of Endorec, Divatron and Injection Maintain.